Right. How is everyone? Guys, turn your cameras on. Let me see some faces after a while. Okay. Right. Okay. So today the topic is thrombocytopenia. Now, let me share the screen. Can anyone tell me what you all have learned anything about thrombocytopenia? What does the word thrombocytopenia mean to you? Anything? By the way, apologies if I sound nasal. I'm having a bit of a, who knows, maybe COVID, I don't know. Right. Right. So tell me, guys, what do you all know about, what does the word thrombocytopenia mean to you all? Anything at all, right? Unmute.
Low platelets.
Sorry?
Low platelets.
Low platelets. Right. Excellent. Okay. Anything else? Anything else you all know? Let me, I cannot see your faces at the moment. Right. There we go. Okay. I can see you all now. Low platelets. Okay. What else? Yes. Decrease in platelet count. Yes. Good. Anything else? What can cause low platelets? Any idea about that? Don't worry. We are going to discuss all of these. What do you all think can cause a reduction in the number of platelets?
A severe infection.
Severe infection. Okay. Right. Anything else?
Bone marrow suppression.
Bone marrow suppression or some okay, right. Bone marrow suppression, you mean by what? By how what is your basis there? By a drug or by some disease?
By some disease, like a
by some disease. Right, good. By some disease, right, good. Also by drugs, we'll see some drugs as well. Right. Okay, so thrombocytopenia, guys, this is basically, we are going to talk about what happens in our body, or a set of diseases. We are going to mainly focus on 3 diseases. We are going to talk about several others, about 2 or 3 others, which are minor ones, which are not very important, but we'll just mention them as we go. Mainly 3 diseases associated with the reduction in the platelet number in our body, right? So when platelets go down, guys, in our body, now this is since your school days, you know this, no? Platelets are essential for what we call coagulation, clot formation, right? So when platelets reduce, naturally, the thing that should come to your mind is it's going to cause excessive bleeding, right? This is what we call a bleeding disorder, right? So today we are going to start off from this bleeding disorders, right? So in order to understand what a bleeding disorder is, we should first understand what's the normal physiology of bleeding, right? How bleeding occurs and how it is stopped, right? So this is what we're going to start with, guys. Hemostasis. This is our physiology class for today. Physiology part for today, right? Hemostasis. We're going to start off with hemostasis. Now, when you all hear the word coagulation, what is it? How do you all define the word coagulation? Clotting. Okay. Further, more explanation. I don't know the word clot. How would you explain it to me? Anything? Think. You all have done, I know you all have done coagulation pathways since grade 8. Okay, right? The grade 8 or 7, I don't know, maybe. Right? So what is this coagulation? What is happening there? What is happening there?
Then platelets stick together on a fibrin mesh. Good.
Platelets. Platelet is going to form a plug, and then there's going to be a fibrin mesh. Good. And yes, Nihal, what you said is also correct, right? Stopping of bleeding. This is what I want you all to know, guys. Our cardiovascular system, it's a system of a pump. There is a pump, right? Then there are some tubes or some pipes, and through that there is a liquid flow, right? Which is blood. Now, the special ability of our cardiovascular system is right? Throughout the body, the blood is in this liquid form. It's like a fluid going through a pipe. But whenever there is a damage to this pipe system, right, or this vasculature, what's going to happen? That liquid, guys, it is able to convert into first a semi-solid, right, and then eventually a solid, and prevent further leaking out of the liquid, right? Prevent, basically the liquid can convert to a solid, right? This is a special property of our blood whenever necessary and wherever required, right? So it's a highly controlled process. So let's see how this is happening, right? The end result of hemostasis, guys, what I want you all to know, you all are correct, right? Stopping of bleeding. The last step there is what is important, guys. We will, don't worry, we will talk about all of these, right? There is something called fibrinogen that is converted to fibrin, right? And this is the end point, right? This is the end point. Now, how we get here is what we are going to discuss now, right? Right. Look at this, guys. So we'll first look at the features of a healthy endothelium. If we look at a healthy endothelium, guys, right? Healthy endothelium has several mechanisms to keep the blood in the liquid form and only form coagulations or clots wherever is necessary, right? Let's see what these mechanisms are, right? Just draw a vessel, guys. We'll draw a bit of a large vessel, right? The blood vessel. That. Right, and I will draw the basement membrane there, right, and some cells. This is what? These are vascular endothelial cells, VEC, vascular endothelial cells, right? Can put something here as well. Something. The first feature, guys, that we're going to talk about the healthy endothelium is that it is able, the vascular endothelium is able to keep platelets inactivated when they are not necessary, right? Because platelets, guys, if they are activated unnecessarily, what will happen? Clot formation. So the first feature that the healthy endothelium can do is keep the platelet inactivated, right? So we'll just draw platelet somewhere here, guys. These are platelet, These are platelet. Okay. Platelets, before we dive into this topic, what is the normal platelet count in a normal individual, guys? In a normal person? Platelet count, what's the range?
1.5 lakhs to 3.5.
Yeah, 4.5, close enough, right? About 150 to 450,000 platelets per microliter of blood. Okay, per micro. This is the normal range. Okay, and platelets. What are they? Are they? How would you describe a platelet? Now I'm a grade 5 or 6 boy. I'm coming and asking you, what is a platelet? Can you explain to me what a platelet is? What are you going to tell them? What is a platelet? Simple things,
They are fragments from the megakaryocyte.
Fragments, okay. So, would you define them as a cell or are they not a cell? This is the question I want.
Non-cellular, irregular.
Not a cell.
These are actually, guys, so previously, right, there was a concept that these are not cells. These are just particles that are floating around in the blood, right? But what we know now is, right, these are cells, right? These are cells. Platelets are cells without a nucleus. Just like mature RBCs, they also don't have a nucleus, right? Without a nucleus, and they contain cytoplasm, right? They have a cytoplasm. So there is metabolic activity going on, right? They're not just pieces and particles floating around. They're actually cellular components with cytoplasm, just they don't have a nucleus. Now, another point about platelets, what is their lifespan? What do you think their lifespan is?
10 to 12 days.
Excellent. Yes, about, we say 8 to 10 days, right? Some books will say 10 to 12 days, correct, right? Just remember it as 10 days, right? 10 days, about 10 days, right? Whereas RBC, if you all remember, 120-day lifespan. And the size, guys, of a platelet, it is very, very small. We say about the diameter is about 2 to 3 microns. And RBC, guys, an RBC is much larger. Mature RBC measures about 7 to 8 microns, right? So these are just some information about platelets before we move on. Now, here's the important thing. Platelets, guys, these platelets, they have various numbers of receptors, various types of receptors rather, on their surface. Today, we will talk about several of those, right? We will talk about several types of receptors. These receptors will do various functions. We'll talk about several, right? One thing I want you all to know, right? There are certain receptors on the platelet cell surface membrane that help. If a molecule comes and binds to those receptors, it activates the platelet. It activates the platelet, right? Now, what I want you all to understand, these vascular endothelial cells, in their normal physiology, guys, they produce various substances, right? For example, nitric oxide, right? Prostaglandin I2, right? PGI2, right? And ADP, adenosine diphosphate, these kinds of molecules, they produce various things, right? These are the main three that we want to focus on. These molecules, guys, they are produced in normal physiology. Nothing has to happen for them to be produced. Normally, the vascular endothelial cells produce it. They come and bind to these cell surface receptors of the platelet, right? And therefore, inhibit the platelet from getting activated, right? Inhibit the platelet from getting activated. This is one way, right? This is one way how the vascular endothelial cell helps keep platelets inactivated, right? Now, there's another concept I want you all to get into your heads. Don't think that we only need platelets if we have a cut or a wound or something, if you fall down. Don't think like that. What I want you all to understand is every day, right? Thousands of, as your circulation, if your heart is working, if your heart is pumping out blood, as long as your heart is working, as long as blood is flowing through the vessels, every day there is thousands and millions of micro damages that occur within the vasculature, just as blood is flowing, right? As the cellular components knock against the vascular endothelial cells, there are micro damages, right? So platelets are absolutely essential, right? You do not have to have a physically visible wound or a cut or something like that, okay? So they are always there. They are always there doing their work. You don't even know what's going on, right? Right. Then we'll go to the next thing. The next thing, guys, of the healthy endothelium, it does not allow, right? This number 2 does not allow coagulation proteins to be activated. Does not allow coagulation proteins to be activated unnecessarily, right? Now, how these coagulation proteins get activated, all of these we'll talk about. Just know there is something called coagulation protein. These are what we call clotting factors, right? You all might have heard, 1, 1A, 2, 2A, 3, 3A, like that. It goes on. We'll talk about those today. But just know for now, unnecessary activation of those will cause problems. So our vascular endothelial cell, it prevents this. How does it do this? Right? Draw another small vessel, guys. Another vessel. Right? Again, the same vascular endothelial cell. Something like that. Right? Look here. Our vascular endothelial cells, guys, they have several special receptors, right? One of them, you can draw it like this. One of them, draw it like a letter H. I will tell you what it is. This is a receptor. This is a special molecule present on the vascular endothelial surface. Another one, draw it like a letter M. M. Right? This is another receptor, right? M. This H, guys, this H is heparan sulfate, what we call heparan sulfate, right? And this T here, this is called this M, this is called thrombomodulin. The M is for the modulin, thrombomodulin, right? Thrombomodulin. These are expressed on the surface of our normal vascular endothelial cell, normal, not the damaged one, the normal one. Now let's say somewhere else, guys, somewhere else in the body, later in the blood vessel, somewhere here, there is a cut, there is a wound or something that has happened, right? So in that area, platelets would have got activated, right? The clotting factor pathways would have got activated, right? All of those will be happening in that area. Now, as the blood is flowing, some of those activated clotting factors, right, can arrive in this place. Some of these activated clotting factors, as the blood is flowing like this, some activated coagulation factors will arrive, right? These are some activated clotting factors, right? Now, what's the important thing here, guys? This heparan sulfate acts as the receptor site to a special protein, right? He has a mouth like this. What is this? Antithrombin 3. Antithrombin 3. Once antithrombin 3 is bound to heparan sulfate, it gets activated and the mouth opens, right? Mouth opens, what can it do? It can take up, it can bite these and swallow them off. These activated coagulation factors, right? Okay. So thereby, the healthy endothelium areas, because healthy endothelial areas don't require these activated coagulation factors, right? Understandable. Then another thing that can come here, guys, again, if a clot is happening somewhere else, another thing that can come here are these fibrins. Fibrins from the other area, they also can come along with this blood, right? Fibrins, right? Fibrin, right? Fibrin, we will talk about in a little moment. Keep that for a while, right? Then, guys, we'll go to this clotting factor again. There are some specific factors that we are going to talk about, some special ones, right? For example, one called factor 5A. 5, and when we put the A, guys, this means activated, right? Activated, right? Another one is 8A. 8A, 5A and 8A, right? 5A and 8A, guys, specifically will be broken down with the help of this thrombomodulin. How does it do this? Thrombomodulin acts as, right, a receptor site. Okay, it binds with thrombin. Thrombin. Don't worry, I'm going to teach you all of these. Thrombin is another name for factor 2A, right? Don't worry about this. The thrombomodulin thrombin complex will activate another protein called protein C. I know this is a lot. Don't worry. Protein C, right? Protein C. This protein C is the important guy here, right? How it gets activated is with the help of thrombomodulin and thrombin. Protein C, this is an anti-clotting agent, right? Or an anticoagulant agent. What it does, guys, it takes this 5A and 8C and it eats them up, right? You can draw it as a mouth or something. So 5A and 8A, 5A and 8A. Protein C will eat them up. Antithrombin 3 here, the ones that we drew. Specifically, this guy is very helpful in disintegrating factor 10A, right? And sometimes some thrombin as well activated, right? 2A as well, right? So in this way, these clotting factors, unnecessarily activated ones, which are coming from another injured site, will be stopped from performing their actions in the healthy endothelial areas, right? Okay. Later we will see, guys, why deactivating this 5A, 8A and 10A are specifically important, right? And 2A also, right? Why these ones we are talking about mainly, we will see when we come to the clotting pathway. Then we'll come back to this fibrin. We said from the damaged area, some fibrin also can come, right? When fibrin comes, guys, there is another mechanism for that. Our liver, right? We'll draw the liver just outside. You all know our liver produces a lot of proteins, no, guys? One very important protein is something called plasminogen. Plasminogen, right? Plasminogen. This plasminogen, guys, when it is traveling, right, our vascular endothelial cells produce another molecule, right? We call this TPA, tissue plasminogen activator, right? These are serine protease, guys. These are protease, right? What is going to happen, guys? Plasminogen, it will react with this tissue plasminogen activator and it will get activated. When plasminogen gets activated, we call it plasmine, right? Plasmine. Okay. And this plasmine, guys, this is what? This is a crocodile. Huh? You can draw a crocodile. I don't know what I do. Just draw a crocodile with an open mouth or something. Yeah. There we go. This is plasmine. Plasmine, what does it do? It eats up fibrins, guys. Unnecessary fibrins will be eaten up with the help of this plasmine. Plasmine. So can you all see how our vascular endothelial cell under normal physiological conditions are preventing unnecessary clot formations, right? Now just think, guys, whenever there is a vascular endothelial cell damage, let's say, now don't draw it in this vessel. I will just draw it for the sake of your understanding. Otherwise, you all will ruin your diagrams. Let's say there is a break here, somewhere here. There is a break in the vascular endothelium, right? A damage like that. Now, will this area have heparan sulfate? Will this area have thrombomodulin? Will this area be able to produce TPA? No. So none of these clotting factors, none of the, and also here, nitric oxide, PgI2, nothing will be produced, right? So none of those factors can work there when there is damage, right? So therefore, clotting occurs. That's why clotting occurs, guys, wherever it is necessary. If unnecessarily it occurs, we call these are pathology. We call it, you all will learn something called disseminated intravascular coagulation. Clots happening all over the body, right? We will talk about that later in another chapter, right? So this is how our body maintains this. These are the two basic mechanisms, right? What I want you all to understand. Now once we have understood how in normal physiology, the blood is kept liquid without clotting. Now we'll see what happens when there is a damage, right? That is our next part. What happens when there is endothelial cell injury, right? Endothelial cell injury. What is going on here, right? So we'll draw a diagram like this. I will change the diagram a little bit, right? Again, you all can draw the vessel, right? Something like that. Basement membrane. And you can draw there. Here we'll make a small change, right? We'll draw damage here, right? Damaged, huh? Let's see what is going to happen here, right? Right. Here, guys, one thing we are not going to draw, we'll discuss that first and get it out of the way. Huh? One thing that almost immediately happens, guys, is with vascular endothelial cell injury. One of the first things that happen, right, is vasoconstriction in that area, right? Vasoconstriction. Why does vasoconstriction happen? Why? Not how. Yeah, to try and reduce the bleeding, right? When the vessel constricts, there is less blood flow. So to try and reduce the bleeding, vasoconstriction happens. How this happens is, guys, several ways. One is the damaged cells are capable of producing something called endothelin, right? Which is a vasoconstrictor agent, right? So endothelin will increase. Then, do you remember we talked about some substances normally released from the vascular endothelial cell? For example, prostaglandin I2, PGI2, right? And nitric oxide. Now, when there is endothelial cell damage, what will happen to their release or production in that particular area? High or low? High or low? Huh?
It's low.
Right? Yes, when the cells are damaged, they cannot release those. So these ones reduce. These ones, guys, usually these act under normal physiology. PgI2 and nitric oxide act as vasodilators. Vasodilators under normal physiology. But now when they reduce, what is happening? It's going to oppose the dilation. So now it's going to further aid in the constriction, right? Okay. Then, guys, there is another mechanism how this happens. This is sort of like automated process. This is what we call a myogenic reflex. There is a myogenic reflex going on here, guys. Damaged vascular endothelial cells, they stimulate the smooth muscles to contract. Vascular smooth muscles. Vascular smooth muscles contraction, right? So when the vascular smooth muscles contract, guys, that also helps the vessel to contract. So these are some ways how vasoconstriction happens. This is one of the first steps when there is an endothelial injury, right? Okay. Then we will go to the clot formation and all of these things now, right? Let's go step by step. Look at this, guys. When vascular endothelial cells are damaged, they release two major compounds. Look at this. One, and I will draw the other one on this cell, two. These two are very, very important for us, right? First one is something called von Willebrand factor, VWF, right? Von Willebrand factor. Now you all will learn more about this factor when you come to the von Willebrand disease. That is covered in one of the next chapters, right? Is von Willebrand factor, and the other one is, guys, something called tissue factor. Tissue factor, right? Tissue factor. This tissue factor we will talk today later in the discussion, right? So we'll leave tissue factor for us a bit. We'll leave it on the side. Now we will go with this von Willebrand factor story. What is happening here? What I want you all to understand, guys, when the damaged endothelial cell releases von Willebrand factor, it looks something like this. You all can draw it exactly like this. Huh? Very long chains, right, of von Willebrand factor, right? Very long ones. We call these guys von Willebrand multimers. Von Willebrand multimers, right? Okay, multimers. They're very long structures, right? Now, if we have very long structures, right, and the damaged area is much smaller, right? What do you all think? There is a small functional problem, no? So because of that, under normal conditions, these von Willebrand multimers are, guys, usually broken down into smaller structures, to optimize the function, right? So eventually it will look like this. Just draw V and W, huh? And they come and line this damaged surface. VW comes and lines this damaged surface like this, right? Now the multimer has been broken down and they come and line the damage, especially this damaged basement membrane will be nicely lined by this, right? By the von Willebrand factor, right? Von Willebrand factor. Now, I want you all to take this into your mind. Huh? This does not mean that the von Willebrand multimers are dysfunctional. Multimers also can form clots. But for the ideal, most efficient clot formation, our body prefers to have them in much smaller forms, monomeric forms, right? So this is why we cleave them, right? And nicely lay them down on the damaged area, right? This is the first thing. Now, how is this done? How is this von Willebrand multimers cleaved to form this smaller von Willebrand structures? This is where our next fellow comes. You all can draw him. You all know Adam Sandler, no? If you all can draw Adam Sandler, draw Adam Sandler. Why? This protein is called ADAM. ADAM TS13, right? ADAM TS13. Just remember it as ADAM. Nothing much. This is another protein, guys, but it is produced again from the liver. Produced from the liver, right? ADAM TS13 is the guy that breaks down 1 milliband multimers into these smaller, more functional 1 milliband factors, right? Okay. Right. So this is the first important step, right? 1 milliband factors come and line the damaged endothelial surface, right? Okay. Then we go to the next step, right? Next one, guys, draw the vessel a little bit big because we are going to draw a few things inside this vessel now, right? Right, you can draw it like that. The same thing, same thing. Top one, of course, no need also. We'll use the bottom, right? What did we show? Injury happened, right? Right? And now who has come and lined this place nicely? 1 milliband factors. Right? Right? Okay. Right. Now look at this, guys. Now, what did we say at the start? Platelets have multiple receptors on their surface to do various functions. Another receptor that platelets have, guys, let's say, right, there's a platelet here. Platelet is now just traveling around the circulation. And suddenly it sees these 1 milliband factors, guys. Platelets have a nice receptor, right, for 1 milliband factor, right? This is a receptor for this 1 milliband factor, right? So what will happen, guys? Platelets will come and bind to 1 milliband factor, right? This is the first step, right, in the clot formation. Platelets coming and binding to 1 milliband factor. This is, guys, this receptor that platelets have, this special receptor that platelets have, this is called, don't worry, these names, they are not highly important, but once you understand their names, you will understand the pathology, the diseases we are going to talk about. This is called glycoprotein 1B. Glycoprotein 1B. This is a special receptor. What does this receptor do? Help platelets bind to 1 milliband. Now, platelets bind into 1 milliband factor, guys. This is what we call platelet adhesion. Adhesion, right? Platelet adhesion. This is the word we give, right? Later, we will talk about something called aggregation in a little bit. This is adhesion, right? With the help of glycoprotein 1B, right? Okay. Now, look at this, guys. The moment platelets adhere with the 1 milliband factor, right? The moment platelets adhere with the 1 milliband factor, this platelet wakes up, right? It gets activated, right? When it gets activated, guys, platelets have a number of things that they produce, right? We are mainly going to focus on several things, right? One is, guys, what we call alpha. Alpha granules will be released. Another one we're going to talk about is delta granules. Alpha granules and delta granules, right? These are going to be released. What are these? What are these? Nothing special. Alpha granules. We'll first talk about the alpha, guys. Platelets themselves, they are able to secrete a little bit of 1 milliband factor, right? Platelets themselves. And another very important alpha granule, we'll come to it later in the pathophysiology, is something called platelet factor 4, PLTF4, or in some books you will see it as PF4, right? Same thing, platelet factor 4, right? Don't worry, we'll talk about how those work, right? Then, so those are the main alpha granules. The delta granules, guys, the delta granule that we are going to focus on right? One thing is calcium, Ca2 plus, platelets release calcium, right? Another one is serotonin. Serotonin, activated platelets can release some serotonin, right? These are again delta granules. And another one is, guys, they can release some phospholipids. Phospholipids, right? These are the ones we are going to talk about. Actually, guys, activated platelets release hundreds of different substances, right? These are the ones we are concerned with, right? For MBBS. Okay. Alpha granules, delta granules. Alpha ones mainly some von Willebrand factor and platelet factor 4. That's the most important one there. And in under the delta ones, these delta ones, guys, in some books, some old books, they even call it dense granules. The D, same. Delta granules or dense granules, same. Calcium, serotonin, phospholipids, right? Okay. Now, right? Another thing, guys, another very important thing, you can put this on the top. Another very important thing that activated platelets produce is thromboxane A2, TXA2, right? Thromboxane A2, right? This one, guys, okay, this is by activating something called the arachidonic acid pathway, right? We are not going to discuss that. That physio is not important today, right? They activate something called the arachidonic pathway, right? And the phospholipase activity is going to activate that. And from there, we get the thromboxane A2. Thromboxane A2, look at this. It has some major functions. We'll see what it does, right? Look at this, guys. Thromboxane A2 has mainly two functions. One thing, right? It is a vasoconstrictor, again, a vasoconstrictor, right? So it further helps to reduce the blood flow. Second thing, it is something what we call a platelet aggregator. Aggregator. We'll see how this happens. Don't worry. Platelet aggregator. Just write it down. Right? Now, what I want you all to understand here, guys, right? Remember our healthy vascular endothelium, the undamaged one. We said it's producing certain things, right? This one, we said it produces something called PGI2, if you all remember, PGI2. What I want you all to know, guys, under normal conditions, thromboxane and A2 and PGI2 are in a sort of a balance, right? They are always opposing each other. They are in a balance. When one goes above the other, the opposite action will happen, right? So when thromboxane A2 is higher, vasoconstriction is more, platelet aggregation is more, clot formation is more. When PGI2 is higher, vasodilation will be more, platelets, the clot formations will not happen, right? They are under normal physiology, these two guys are in a balance, right? This is an important point for you all to understand, right? Right. Then we'll come back to our damaged endothelium, right? We'll come back to our damage. Now, what happened? Von Willebrand came, it activated the platelets via the glycoprotein 1B receptor, right? What happens, guys, when this glycoprotein 1B receptor activated this platelet, right? It produced various substances. These are going to cause attraction of surrounding platelets, right? Surrounding platelets. These are like crows, guys. You all know when one crow comes and sees some food, what's it going to do? It's going to shout, right? Then another crow comes, second fellow comes, third fellow comes out of nowhere. Within 5 minutes, what? You have about 100 crows, right? Same situation with these, especially this platelet factor 4, right? Serotonin, phospholipids, all of these coming into play. They're going to attract other platelets to this area, right? What happens, guys? Other platelets now start arriving here. Let me draw it like this, right? Other platelets will start arriving here. Now there is another receptor, right? Another very important receptor on the surface of the platelets, right? You can draw it like this. These are, guys, right? This is the second and only complex one that we have to talk about today. One is glycoprotein 1B, we already talked about. Yeah, this one is glycoprotein, write this down, 2A, 3B, right? This is the full name, glycoprotein 2A, 3B. It's one name. Don't worry. We'll see why learning about this. are important, right, for the diseases. These ones, guys, what do they do? Now, what did glycoprotein 1b do? Tell me without looking. What did glycoprotein 1b do? What did it do?
Helps in attachment to uh, on
Yes, help.
VAW factor.
Yeah, von Willebrand factor, right? Help the platelet adhere to. Use the words, huh? Help the platelet adhere to von Willebrand factor. What does glycoprotein 1b do? Glycoprotein 2A3b do, guys? It helps platelets to adhere to each other, right? This guy, nearby platelets, they will adhere to each other using this glycoprotein 2A3b. This is what we call, guys, aggregation. Platelets binding to each other is what we call aggregation. Platelets binding to one Willebrand, adhesion, right? So with the help of 2A3b, what is happening? Platelets aggregate one on top of the other, right? One on top of the other. So you all can draw something like that. Draw this. I can just copy and paste, but you all can just draw something like this. And now it is going to start aggregating platelets in this damaged area, something like this. Okay, there we go. Now, once this adhesion and aggregation are complete, guys, this is what this structure that we are left with is what we call a platelet plug. A platelet plug. Okay, a platelet plug. Right? This platelet, the steps that we talked about now, right? Until the platelet plug formation, this entire process is what we call primary hemostasis. Hemostasis, right? Until this here, until the formation of the platelet plug, primary hemostasis, right? Okay. Right? So we've now made sort of this platelet plug, guys. It's not exactly solid yet, right? It's sort of like a, it's sort of between a solid and a liquid, right? A semi-solid sort of thing, right? Okay, right? So this is the platelet plug. Now, what should happen? Do you think we should stop the process here? Is this enough to stop the bleeding? Is this enough? No, right? We should convert this to a solid. We should make a full block there, right? So that nothing can leak out, right? So therefore, this primary hemostasis, the primary clot, should now be converted to the secondary one, which we are going to talk about now. How is this done, guys? We are going to add fibrin. We are going to add a nice mesh over this platelet plug, right? For that, we need something called the coagulation cascade. Right. Right. Look at this. Now this one I know. Guys, okay. First draw the vessel. Draw a big one. We again need a big vessel. Take a full page maybe and draw a big vessel. Right. Again, the same one, the damage there. Right. And now you all can draw that plug, the platelet plug, you all can draw it there. So I will draw it something like that. We have formed a platelet plug. Right. Now we'll see the next step. What is going to happen here? Right. Now, a disclaimer before we go. So, when I was studying this, when I was in medical school, I have huge issues with Roman numerals, right? Trying to remember them, where they go, what happens. So, for the rest of the class, and even I think from the start, right, I am going to use normal numbers because that's what I'm familiar with, right? Guys, if you don't use Roman numerals, doesn't mean it's wrong. It's just how it has been named, those clotting factors and all of those. But for some reason, for me personally at least, It's much easier to remember these things because when I see number 9, I know it's number 9. But when I see IX, my head has to go through an extra process, right, to convert that to number 9. So however you all want, remember, it's not an issue. But today I'm going to use just the normal numerals, not the Roman ones. Look at this. Now, when there is endothelial damage, tell me, what are some things that the endothelial cell produces that we talked about? One thing was endothelin. What's the second one that we talked about? What's the second one?
Tissue factor.
Von Willebrand factor. Von Willebrand, especially the multimers, which will then be broken down, right? Another thing we said was tissue factor, right? This is where we come in now, right? We'll take this tissue factor. Tissue factor is going to be released from damaged endothelial cells, from the damaged ones, not from normal endothelial cells. Tissue factor, guys, y'all can imagine it sort of like a tissue juice, sort of, right? When you take a cell, when you take a vascular endothelial cells and squeeze it or damage it, it will start leaking out. That is tissue factor, right? So it's produced from damaged endothelial cells. Tissue factor, what does it do? Tissue factor, guys, it is going to react with the protein in our blood, right, called factor 7. Factor 7, right? Okay, factor 7. This tissue factor and factor 7, right, they react together to form a complex. What is this complex? Tissue factor and 7. Now this complex, guys, once they form this complex, this 7 is in the activated form. So this is a tissue factor and 7A complex, right? Tissue factor and 7A complex. Guys, draw it exactly how I'm drawing, because we are going to use this entire space, right? The tissue factor 7A complex, right? Right. Okay. Then, guys, this tissue factor and 7A complex is going to activate another one, right? Another one called factor 10. It's going to activate it to what we call 10A, the active form, 10A, right? How do these activations happen, guys? These activations happen from cleavage. For example, the 10 will look something like this. The 10 will look something like this. When it is cleaved, what will happen? This will be separate and this will be separate, like this. Now, this portion is active. This portion is active, right? This is how these are activated. I just do it on the side. You all don't need to draw this. Okay. So 10, factor 10 is activated to form 10A, right? Okay. Now, this 10A is one of the major players today, guys. This activated factor 10, right? What does it do, guys? Activated factor 10, right? With the help, you all can write down, with the help of calcium. We saw calcium being released from the activated platelets. Do you all remember? As a dense granule, right? Calcium, and with the help of some phospholipids. Phospholipids, just on the surface of the platelets itself, they are made of phospholipids, right? With the help of calcium and phospholipids, they are going to break down another factor, right? And thereby activate it. This is factor 2, which will be going to factor 2A. Sorry, 2 going to 2A. What is the name of this 2 and this 2A? 2, guys, we call it prothrombin. Prothrombin. And 2A is what we call thrombin. 2A is thrombin. Okay. Now this 2A has multiple functions, as we'll see today. Okay. Right. Draw this a little bit lower. right? Okay. Let's see what this thrombin does, right? What this thrombin does. This thrombin or activated factor 2, what it does is, guys, one of the major function it does, right, is that it breaks down fibrinogen to fibrin. This fibrinogen is what? This is factor 1. What is fibrin? 1A, or activated factor 1A, right? Okay. Now this fibrin is what is going to cause fibrin monomers, guys. They are going to come and settle on this, right, and form a mesh-like structure, right, and thereby fully solidify this platelet plug. Okay, this is what fibrin does, right? Now, here's a very important thing to know. This entire thing that we talked about up to now, right? Take your skeletal notes, guys. It's there. The same thing is there in your skeletal notes, known as the extrinsic pathway or the tissue factor pathway. This thing, right? This thing. See how complex this diagram was versus what we drew. Very simple, no? Right? Okay. Same thing. Don't worry, we are going to add more to this. This is the same basic. What we looked up to now, this is the extrinsic pathway. Now, why did I draw this first? Extrinsic pathway, guys, it occurs very rapidly. Right? And it often occurs first before the intrinsic pathway, right? This happens very rapidly and first, right? Now then we'll see what happens next, right? What I want you all to know here, guys, from the extrinsic pathway, this tissue factor induced extrinsic pathway, this tissue factor, if you all want, tissue factor, another name is what? Factor 3, right? So this is what tissue factor 7A is 3A 7A complex, same thing, 3A 7A complex, right? Right. Okay. Then here's the next thing I want you to know. From this extrinsic pathway, guys, the amount of fibrin, now what is the end product? Fibrin. The amount of fibrin produced from this extrinsic pathway is very little, right? From the extrinsic pathway alone, the amount of fibrin produced is very little. So what do we need? We need a lot more to try and seal this clot nicely. This is where the intrinsic pathway kicks in, right? We'll talk about that in a little. Before we go there, we'll look at the other functions, right, performed by this thrombin and this some other stuff. Look at this, guys. Draw this here. We'll draw this arrow nicely here. This is one function of the thrombin. The major function of the thrombin is the conversion of fibrinogen to fibrin. Another important function of the thrombin, guys. Look at this. From the same arrow, you can draw. Another important function of thrombin, right? It activates something else. What? This guy activates something called factor 5 to form factor 5A, right? Factor 5A. And factor 5A does what? Further enhances this process. Conversion of 10A, right? The activity of 10A, right? Factor 5A helps in that, right? So this is sort of like a what? This is like a positive feedback loop, right? This is like a positive feedback, right? Okay. Right. Then, guys, this tissue factor here, the tissue factor here has another job. You can draw it in a dotted line. We'll draw it in a dotted line because we need to bring it all the way here, right? This tissue factor and the 7A complex, basically 3A 7A complex. What it does, guys, it helps in the conversion of something called factor 9 to 9A, right? Factor 9 to 9A, right? And this 9A can do what? Further help conversion of 10 to more 10A, right? More and more 10A, right? Okay, right? Okay. So we have now looked at two functions of thrombin. One is conversion of fibrinogen to fibrin, other one 5 to 5-way, 5 to 5-way, right? Okay. Another one function, guys, we have to do this. Let me draw this here. 5 to 5-way. Another one function, the last one rather, of thrombin, you all can draw it from that same arrow, extending from that same arrow, right? Is the conversion of 8 to 8A, right? 8 to 8A, right? And 8A does what, guys? It helps with the function of 9A, right? 9A, right? Now, what do you see here, guys? What do we see here? This thrombin is one of the major players, right? There is one more function of thrombin. I know there is a lot. The last one. Look at this. Conversion of something we call factor 13 to 13A. 13A function, guys, I will teach you all. Don't worry. 13 to 13A. This is a special guy. This 13, factor 13 is quite important. We'll talk about that in a little while. Right? So these are the main points regarding this extrinsic pathway. Right? Okay. Actually, guys, this 13 to 13A, shall we draw it somewhere here? I'm sorry, we'll draw it somewhere here because we need that other side. 13 to 13A. Somewhere here. Sorry if you all already drew it. All right. So now what happened, guys? From the intrinsic pathway, our body was able to lay down some fibrin, but still not sufficient enough, right? To stop the entire bleeding. Okay, to stop the entire bleeding. So thrombin has how many functions? We have talked about 4 now, right? Major function is fibrinogen to fibrin. Then activation of 5, activation of 8, and activation of 13, right? Factor, right? Now, what did we say? This is still not enough. This fibrin is still not enough. This is where the intrinsic pathway kicks in, guys. Look at this. Our liver, in the same diagram you all can draw, our liver, guys, produces most of these factors, right? Most of these factors are produced by the liver, right? Except, of course, tissue factor, right? What happens, guys? One of the important clotting factors produced by the liver is called factor 12. Factor 12. Factor 12, guys, another name we call this contact factor. Contact factor. Why do we call this contact factor, guys? This factor, once it comes into contact with the damaged vascular endothelial cells, it gets activated. It becomes 12A. 12A, right? It just contacts with the damaged endothelium and gets activated. 12A, right? Okay, right? Then what happens? This 12A goes and activates what? It helps in the process conversion of 11 to 11A, activated factor 11, right? 11 to 11A. And 11A does what, guys? It goes and helps in this conversion of 9 to 9, right? So this is the extrinsic pathway. From there onwards, from 12, 11, then 9, from 9 it comes to the 10. From the 10 downwards, guys, from the 10A downwards rather, right? From this 10A downwards, this is what we call the common pathway. From the 10A downwards, we call the common pathway because as you can see, the extrinsic pathway also activates this 10 and the intrinsic pathway also activates this. Eventually, from there downwards, it's called the common, right? So from this contact factor up to the factor 10, that is the intrinsic pathway. From the tissue factor up to the factor 10, that is extrinsic pathway. After the factor 10, it's common pathway, right? Now what is happening? Now there is going to be a lot of, because this intrinsic pathway also now kicked in, so a lot of factor 9 is going to get activated here, a lot of factor 9 activated, that is going to activate further a lot of 10, right? Therefore what is happening? A lot more thrombin is going to come, and thrombin is going to break down fibrinogen into fibrin, a lot more fibrin comes. Now we are going to nicely seal this, right? Form a nice solid structure with a lot of fibrin and okay? Insoluble fibrin, insoluble, right? Once this is complete, the hemorrhage will be terminated, right? Bleeding stops, bleeding stops. Okay, is this clear up to this point? Let me see some faces.
Prashan?
Yes.
I have a question. Do
Yes.
we call this the secondary hemostasis? Like
Yes.
we said for the...
Yes, excellent. So now, once the coagulation factors come into play and they lay down the fibrin, this is what we call the secondary hemostasis, right? From the basic platelet plug until the fibrin monomers come and deposit, that is called secondary hemostasis, right? Okay. Once this is complete, hemorrhage completely stops, right? Okay. This clotting factor pathway, guys, I do not want you all to remember, right? It's not necessary for you all to memorize this, right? But just have a basic understanding. One thing, that the importance of thrombin here. That's the first thing I want you all to know. Thrombin has multiple functions. And the second thing, I want you all to remember the end product of the clotting cascade. It is the conversion of soluble fibrinogen into insoluble fibrin. If you all understood that much, more than enough. Okay, from MBBS level, definitely enough. Okay, right? Okay, clear. Now look at this, guys. Now, once we have discussed that, right? Let's go down. We'll talk about the bleeding disorders. Now you all can put the topic, bleeding disorders, right? Bleeding disorders. Here, guys, you all can put some names here. I will teach you all some names here. Here, when 5A and 10A get together. Now, did you all see a 5A coming and joining together with 10A to do a job, right? When 5A joins together with 10A, we give this a special name. The molecule here, we call it prothrombinase. Prothrombinase. You all understand that now? Why? It cleaves prothrombin, right? Prothrombinase, right? Then here, 8A and 9A getting together. Here, What do you all think this is? This factor here. Can you all guess? Make a guess. 8A and 9A getting there. What are they doing? What are they doing? Any guesses? Very easy name. No guesses. 10 A's. 10 A's. Right? Very easy, no? Right? It breaks down. It cleaves 10. Right? Factor 10 to form 10A. Right? These are just some names, guys. When y'all are reading textbooks, these names come up. That's why I want y'all to understand. So if they say prothrombinase, nothing special, just 5A and 10A together. Right? 10A's, 9A and 8A together. Right? Right. Now, here y'all can put some side notes, guys. Before we go into these bleeding disorders, I will teach you all those also. One, y'all can put it as a side note. Note. One important point I want you all to know. There is something called, guys, protein C, right? Protein C. Protein C, it inhibits, it is able to directly inhibit factor 5A, right? So what do you think? Protein C is a procoagulant or an anticoagulant protein? What do you think? Guys, anticoagulant, obviously no. So what will happen when 5A is inhibited? Prothrombinase formation reduces. When that happens, prothrombin cannot be broken down, right? That's one thing. Then protein S, guys, we already talked about, right? Protein S we already talked about, right? Protein S, right? We drew it here, remember? Go up a little bit in your diagrams. We talked about here, right? With the help of thrombomodulin, and thrombin, right? Protein C we already talked about, right? Protein S is another one. So protein C 5A and it can cleave 8A as well, right? Protein S, guys, protein S is a special one. This guy can directly inhibit 13A, right? We'll talk about the importance of this later, right? I will teach you all this later, right? Okay. Then antithrombin 3 break, it inhibits what, guys? Do you all remember? Main one what? Very important one I want you all to remember. When you hear antithrombin 3, that should come to your mind. 10A, 10A, this is the main one. 10A can be inhibited, and then to some degree 2A also can be inhibited. But this 10A, don't forget, that's the major player there, right? Antithrombin 3. Right? Okay, now we'll come to this bleeding disorders topic, right? Here, guys, right? One of the first things I want you all to know are some terms. Look at this. First one is called the absolute platelet count, right? This one everyone knows. No, what is this? This is the total number of platelets. You all can write this down. Total number of platelets, right? Everyone understands that. Second one is what we call, guys, bleeding time. Bleeding time, BT, right? Bleeding time. This bleeding time is basically after an injury for how long you're bleeding, right? But this is a little bit different. This is a deliberate lab test, guys, right? You can't cut yourself and count how long you're going to bleed for and then decide that that's your bleeding time. No, that is not what this is. This is, guys, this is a measure, write this down, a measure of the vascular response plus the platelet response together. Vascular response plus the platelet response. Now a question comes, what is this vascular response? What is this platelet response? Put a side note, right? No. Right? For the arrest of bleeding, guys, we mainly have three responses. One is what we call the vascular response. Don't worry, I will explain. Second one is what we call the platelet response, right? And the third one is what we call the clotting factor response. clotting factor response, right? So when we say vascular response to arrest bleeding, what should come to your mind? What is it? What is this vascular response to arrest bleeding?
Vasoconstriction.
Vasoconstriction. Vasoconstriction. This is what I want you all to understand. Vasoconstriction, right? When I say platelet response, what should come to your mind? What should come to your mind?
Platelet plug.
Platelet plug formation. What's a nice medical sort of way to say it? And scare someone.
Primary hemostasis.
Primary hemostasis. Primary hemostasis. Then when I say clotting factor response, what is coming to your mind? Secondary hemostasis. Right? Okay. So now we have discussed all of these. So this bleeding time, guys, is a measure of how long it takes for your vessels to vasoconstrict in that area, plus until the formation of the platelet plug, right? Platelet response, right? Okay. Right. Then the next term, guys, the next term is something called the PT, prothrombin time. Write this down, prothrombin time. Prothrombin time. Right? Now these ones, guys, just from the words, we cannot understand these, right? Now don't think this is the time taken to break down prothrombin or something like that. No, we cannot exactly say that. Prothrombin time, these are lab tests, guys. The names they have just assigned to them, right? This is a lab test that measures the entire extrinsic pathway. Extrinsic pathway. I will give you all a mnemonic to remember, don't worry, right? This measures the extrinsic pathway. Then we have a fourth one, right? PTT, right? We call it partial thromboplastin time. Partial thromboplastin time. This one measures the intrinsic pathway. Intrinsic pathway. Don't worry, I will tell you, right? Here, guys, before we give the mnemonic, just note, now this PTT, the easier way to look at this in the lab, right? If you're a lab technician, is what we call APTT. It's the same measurement of the intrinsic pathway. But the difference is, guys, in the lab procedure. In the APTT, we are testing the same thing, but what we do, we add an activator. We add what we call an activator, right? To what? To speed up the entire process. This activator, when you add, it speeds up the coagulation process, speeds up the process. So what happens? It helps you in the lab, right? You don't want to spend hours and hours waiting for to measure the intrinsic pathway. You just add the activator and then you get a range. Now, what's the difference in this? You're testing for the same intrinsic pathway, no difference. The only difference is you get faster results. Faster results. So it helps in the setting of a lab, right? Faster results. Just know, guys, faster results, but at the same time, the reference range is a little bit narrower because this is happening very quickly, right? So the margin for error can be a little bit higher than PTT, but it's not an issue, right? So now when you look at a blood report, it always comes PT, then APTT, right? From hospitals and all, you don't usually get PTT, right? Same thing. It's just they add another secondary activator there to speed up the process. Now, how to remember these two? PT, guys, write this down, right? Play tennis. Where do you usually play tennis? We play tennis outside, right? We play tennis outside. Then PTT, play table tennis. Table tennis is usually an indoor sport, right? So play table tennis inside. So I know tennis can also be played indoors, right? Now don't argue with me. What I'm saying is usually we play tennis outside in the sun, right? So PT is extrinsic, outside. PTT, inside. Okay? If you all can remember that, more than enough. Because there is no other logical way to remember this using the names, guys. Right? Okay. Right. Okay. Then we have a little bit more, some more terms. Number 5, something we call thrombin time. Thrombin time. or TT, right? Now don't take this as table tennis, huh? Okay, that was for PTT. This is thrombin time, huh? Thrombin time, guys, this is, right, a measure of the time of the conversion of fibrinogen to fibrin. This is basically, we are measuring the time taken for the very last step of the entire clotting response, clotting factor response, right? That measuring just the very last step, right? See, if it was someone like me, I would have named it fibrinogen time or fibrin time, right? But they named it thrombin, right? So don't mix up the things, huh? What to do, right? Right. Then the last one, guys, I want you all to also know something called international normalized ratio, INR, right? International normalized ratio. What is this, guys? This is basically a standardized test, right? So that we can compare the values across all patients, right? What we do here is, guys, we take the patient's prothrombin time, and we divide it by a set standardized prothrombin time. So for a particular age, right? Or sometimes for a particular area in a different country, it might vary, right? So there are standardized prothrombin times, right? People in this group should have this much. So we take the patient's one and divide it by that. So it should be equal to 1.0, right? It should be equal to 1.0 under normal circumstances. Now, if the international normalized ratio is greater than, if it is greater than 1.0, what does that tell you? What does that tell you? What does that tell you?
High PT time.
High PT, increased prothrombin time. If the prothrombin time is increased, that means what? The extrinsic pathway is taking a long time. Now, out of the intrinsic pathway and extrinsic pathway, which is the first one to occur? Which is the fastest one to occur? Which one?
Extrinsic.
Extrinsic pathway. Now, if PT time is high, what does that mean? It takes a long time to initiate the clot formation. What does that tell you? What will happen? Will this patient bleed for longer than normal, or will he bleed only a very short time? What do you think?
Bleed longer.
He will bleed longer. So what does that tell you? Increased bleeding time. Okay. This is what's important, right? So we want the INR to be at 1.0, right? If it is higher, problem. Okay. Right. Then we'll move on, right? Now, what did we say? When we have a bleeding disorder, we mainly have three: the vascular response, platelet response, and the clotting factor response. Now, we'll leave the vascular response aside, guys. That's for another day, because let's talk about the bleeding disorders. Look at this. Put another small chart there. Bleeding disorders. Here, guys, we again look at this vascular problem. So we'll have, now you can put it as problem, huh? Vascular problem, a problem with the platelets, or a problem with the clotting factors, right? Very easy, right? The vascular ones, guys, we are not going to discuss today. That is not our topic. So you all we'll just get it out of the way. There are many causes, guys, right? Some of the main ones I want you all to know here, right? When it comes to vascular problems, congenital issues, congenital problems, right? Of the vasculature. So these are, guys, usually collagen problems, right? So there is something called Ehlers-Danlos. Have you all heard? Right? Ehlers-Danlos syndrome, right? We're not going to talk about these. Huh? There is another one, hereditary telangiectasia. Just write them down. If you all want later, you all can read them. They are not today's topic. Right? Then we have other acquired vasculitic disorders. Vasculitic disorders. Right? Then another one, guys, you all can just add here scurvy. Have you all heard scurvy? Vitamin C deficiency, right? This also it results in a vasculature problem, right? There you will get gum bleeds and things like that. We are not going to talk about that, huh? Because of the deficiency of vitamin C. Today, we are mainly going to focus on this platelet and the clotting factors. Out of that also, guys, our topic today is thrombocytopenia. So we are going to focus on these platelet problems. Now, take your skeletal note, guys. There is a table. Let's fill that table, this one. When we have this platelet, either a problem in the platelet or a problem in the clotting factors, how can we differentiate between the two based on what we see in a patient? Right? This is what we're going to talk about now. First thing, if you look at the bleeding, where the location is of the bleeding, usually, guys, platelet disorders, you see the bleeding very superficially. Superficial bleeds, right? Superficial bleeds. What are these superficial bleeds? Usually the skin, right? Sometimes the gums, right? Subcutaneous tissue, basically, right? Then, guys, in very rare cases, you all can put it there. In rare cases, there can be gastrointestinal bleeds, right? Or intracranial hemorrhage, especially in the small vessels of the brain. But these are very rare. For the most part, when there is a platelet disorder, you will see it as generalized skin bleeding, right? We'll talk about petechiae, chymosis, all of these we'll talk about, right? And the gum bleeds. Whereas if there is a problem with the clotting factor, guys, right? If there is a problem with the clotting factor, the bleeding is usually deep, right? Especially in joints. What do we call it? When there is bleeding into joints, we call it hemarthrosis. Hemarthrosis, right? Or in muscles, muscular hematomas. Hematomas, right? When there is a clotting factor problem, right? Okay. Right. Then, if you look at the clinical picture, guys, right, you will see what we call petechiae. Petechiae, or we call it, you all can pronounce this however you all want. For a few years, I called it purpura. Then some other people influenced me to call it purpura. Right now, I don't actually know what to call it. I just say whatever comes. Right? Anything. Right? Don't worry, I will teach the difference between these in a little while. Then, so these are usually small bleeds. Small bleeds. In the clotting factor problem, guys, you usually see, guys, what we call ecchymosis. ECCHY. Ecchymosis. Right? Ecchymosis. Right? Now, why do you think this is, guys? Platelet disorders, why do we usually see petechiae and purpura? Whereas clotting factor, we see larger extravasation of the blood. Anyone? From the mechanisms that we just talked about. Understandable, easy logic, no? Platelets were involved in what? The plug formation, the primary hemostasis, right? Clotting factor does the major part. It does the secondary, it nicely seals the one. So if the sealant is not there, bleeding will be much more, right? So larger, ecchymosis. Platelet disorders will be tiny, right? Next one, bleeding on a minor cut. Now tell me this based on your logic. In a platelet disorder, what will you see? Will there be bleeding or no? In a minor cut and in a clotting factor disorder. Minor cut means a very tiny cut, guys. Very tiny cut. What do you think? Think. We are not talking about large cuts now. Just a tiny cut. Just try to think logically. What do you think?
Less, because the platelet blood.
Okay, wait. bleeding on a minor cut in a platelet disorder, yes or no?
No.
Yes or no?
No.
Okay. In a clotting factor disorder? So you are saying in a clotting factor disorder what?
Yes, we have.
Now you have to change your thinking. Huh? This is not the thing. Look at this, guys. When there is a minor cut, right? What did we say? First, we have the primary hemostasis. The primary hemostasis can block the bleeding for us to a certain extent. But the secondary hemostasis is what comes and nicely seals up everything. Now, if there is a very minor cut or a very minor injury, right? If the platelets are not there or if they're dysfunctional, even in a minor cut, what will happen? We will see bleeding. Why? The plug cannot form. Plug cannot form, right? Even in a minor cut, you will see bleeding. But if there is a minor cut and the clotting factors aren't working, what will happen? Bleeding will be minimal. Why? We can still form the plug. Platelets are fine. Platelets are fine, right? So this will be minimal, or you can say no or no, right? Why? Platelet plug is still forming. That minor cut, right, will be obstructed by the platelet plug. So even the clotting factors are not disordered to a major extent, the blood flow will be stopped, right? Okay. Now tell me this. Without the platelet plug formation, if there are no platelets in your body, tell me this. If there are no platelets in your body, can the clotting factors alone stop bleeding? Can they alone stop bleeding? This is what you have to understand here.
No.
No, why? What do clotting factor? What is the end of the pathway of the clotting factor pathways? Fibrin. Fibrin is what? It's just like a mesh. If you just put a mesh, right? Imagine like a mosquito net. If you cover the cup of the mouth of a cup with a mosquito net and pour it out, what will happen? Everything will still come out, right? Right? But what if you put the mosquito net and just underneath the mosquito net, some solids, you have put some solid, let's say some pulp or something. What will happen? Can the water come out? No. That's the difference I want you all to understand. The bleeding on a minor cut when platelets are problematic or when the clotting factor. True, the clotting factors are the major players, but without platelets, they're useless. They're useless, right? Okay, I hope everyone understands, right? Then post-surgical bleeding, guys, especially if a patient who went into surgery, they already had a platelet problem or they already had a clotting factor problem. During the surgery and soon after the surgery, true, before the surgery, we'll give them thromboprophylaxis and all of that. We'll talk about that later. But if they have a platelet disorder, post-surgical bleeding is usually immediate, guys. Immediate and mild, right? Immediate and mild. Whereas if they have a clotting factor problem, their bleeding will be delayed, but it will be severe, right? Severe. Okay. Because why is it delayed? Initially, the plug will form. The platelets are working. The plug will form, but no nice mesh to come and seal off everything, right? So they will have delayed bleeding, but it will be severe, right? Especially we are talking about mainly internal bleeding here, guys. Okay, right? Post-surgical, right? Right. Then we'll come back to our topic, right? Now, right, guys, we will take a 15-minute break and then we'll talk about thrombocytopenia, right? Okay, so we are done with the physiology part, right? Once you've understood so that diseases are going to be very easy. Okay, right. Let's take a break and come. Right. Okay, is everyone back? All right. Now we have the relatively much easier portion to go through. Right. Guys, turn your cameras on. Let me see your faces. Right. Let me share the screen. Right. There we go. Okay. Now, now we are going to talk about the pathologies, guys, the diseases, right? Now we are going to talk about the medicine aspect of this. So thrombocytopenia, we'll start off there. What is the basic definition? Platelet count low, less than what, guys? Usually platelet count less than what? What's the normal range?
Less than 150.
Yeah, 150,000, right, per microliter of blood, right? Okay, right. Now, the causes of this, guys, the causes of this, multiple causes, right? But basically, we can break the causes down into two things, right? Reduced production of platelets, right? Or an increased destruction of platelets, right? Now I have listed all these causes in your note, guys. Okay, so no need to write it down again. So for reduced production, right, various things, congenital issues, drugs, bone marrow failure, right? You all talked about some of these in the beginning. Leukemias we'll talk about, huh? And myeloma also I'll be teaching you all in the upcoming chapter. Megaloblastic and aplastic anemias, infections, all of these infections, guys. Specifically, just remember HIV and hepatitis. These are the most important ones. Apart from this, there are other ones. Even mycoplasma can cause some platelet reduction, sepsis, these kinds of things, right? Not very important. HIV and hepatitis, just remember. That also hepatitis, mainly B and C, mainly B and C. Okay. Then increased destruction of platelets. This is our main topic today, right? We're going to talk about ITP, TTP, right? And then drug induced, we're going to talk about HIT, right? Heparin induced thrombocytopenia. We'll talk about that. Then DIC, we all will be discussing in an upcoming chapter. And hypersplenism, guys, this is basically, right, an increased abnormally high spleen function, right? Spleen function, right? Now, this one has a number of other reasons, right? We're not going to go into pathophysiology of this. Just know the spleen is where everything is broken down. RBCs are broken down there, platelets are broken down there, everything is broken down there. So when there is abnormally increased splenic function, there can be destruction of cells, right? So from platelets also can reduce, right? So we'll start off with ITP, right? ITP. This is our first topic, ITP. What is this, guys? Now, this goes by two names. One is immune thrombocytopenic, and then our favorite word, purpura, right? Purpura, whatever. And then this previously, guys, it was also called idiopathy. The I was previously idiopathy. You can call it anything, because those days they actually didn't know a proper reason. Now we know this is immune mediated, mainly immune mediated. Why I say mainly, we'll talk about, right? So you all can use either, not a problem. Both are the same thing, right? Idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura, right? For some reason, purpura sounds nicer than purpura, right? But I don't know which one's the correct thing, right? Anyways, let's move on. What is happening here? What is happening here? Look at this. Here, guys, okay, we have a nice platelet, right? We have a platelet, right? Now, remember, on the platelet, what did we say? Multiple different types of receptors, right? What are two specific ones that we talked about? Glycoprotein 1B and the other one, glycoprotein 2B3A. 2B3A. This ITP, guys, here the issue comes to this 2B3A. What is this? There is an autoantibody being produced by your body, right? So this is an autoimmune condition, right? Against this autoantibody, you all can write down, autoantibody against glycoprotein 2B3A. See now how the physiology comes into play. Now tell me, if 2B3A is dysfunctional, what is going to happen? What is happening? What is happening?
Platelet aggregation will be
aggregation problem. Adhesion is fine, but aggregation does not occur. Right? Aggregation does not occur. Okay. Right? Okay. Problem with aggregation. Right? Look at this, guys. Now, look at this. When these autoantibodies come and bind like this, guys, right, due to some intracellular pathways, we don't need to discuss that biochemistry level. Just know, due to some intracellular pathways, these platelets, right, these ones get activated. Platelets get activated unnecessarily. They get activated, right? Okay. Unnecessarily, write that word, unnecessarily, right? And the other thing is, guys, what I want you all to know, once these antibodies come and bind, this is one of the first things I want you all to know. Second thing, once these antibodies come and bind, right? Now you all know the platelets, not just the platelets, all our blood cells, they pass through the circulatory system, and at one point they enter the spleen. And in the spleen, there are some, whatever is unnecessary will be broken down. Once these antibodies come and bind to this platelet, guys, the platelet becomes highly attractive, right? Attractive to splenic macrophages. Basically, once these autoantibodies come and bind to this glycoprotein 2B3A, they are marked, these platelets are marked for destruction, right? So the moment they come into the spleen, what happens? The moment they walk into the spleen, right? So they'll come here, right? Let's say this fellow. Now he has antibodies, auto antibodies that have bound to the glycoprotein 2B3A. These ones are extremely attractive, guys. Why? Why? Our splenic macrophages, right? Our splenic macrophages, they have the receptor for the FC portions of these autoantibodies, right? They have receptors for these FC portions of the autoantibody, right? Okay. So what is going to happen? These platelets start, they will be destroyed. When platelets are destroyed, guys, what is happening? Platelet number drops. What does that give you? Thrombocytopenia. Thrombocytopenia. This is the hallmark. Thrombocytopenia is the hallmark of ITP, right? ITP, right? Okay. Right. Now look at this, guys. How can this clinically come to you when you are a doctor? How will this ITP present it, right? Mainly two forms, guys. ITP comes in an acute and a subacute or chronic form, right? The acute form, guys, it mainly affects children, right? So in pediatrics also, you will learn this. In children, this is mainly an acute form, right? You all can write acute form, right? Usually, guys, this is in 3 to 6 year old children. 3 to 6 year old children, it's very common. There's like a peak there. At that age, there is a peak of ITP, right? And then the peak declines, right? And usually, guys, you all can write this down. Usually, write it down. Huh? There is a history of a recent viral infection. History of a recent viral infection. Right? So especially, guys, during this stage, chicken pox, right? Varicella, right? You all know, no? Then measles, right? Usually these kinds of infections or kind of a flu, right? So why is there usually a history of viral infection and then ITP? Why do you all think? Why do you all think? Can you all piece the two together based on the mechanism of ITP?
The infection has similar structure to this thing, glycoprotein 2B3, yeah. Which causes like
you mean the infective agent itself
the
has a
pathogen.
similar structure?
I mean, maybe there is some, I mean, that causes production of the antibodies against the GP2B3, yeah.
Good.
The spleen is activated again. The spleen is activated to produce energy.
No. Okay. No. Okay. No need to go all the way to the spleen, right? So basically, guys, it's not that the viral antigens or viral structures have a similar structure. No, the virus will stimulate the body to produce antibodies. Now, this is an autoimmune thing, no? So you have to think in that way. So the virus will stimulate the body to produce the autoantibody, and that autoantibody will cross-react, right? That autoantibody is supposed to just go and kill the virus. But what does it do? It goes and attaches to 2B3A as well. That is called cross-reaction, right? So that is why this happens. So specifically this varicella, measles, these kind of infections, okay? So the acute presentation, why do we say this is an acute presentation, guys? Usually, right? How does the history come? Doctor, my son or my daughter had a fever, right? And maybe some skin rash. Maybe they're talking about something like chickenpox. About 2 weeks ago or about 1 week ago. Now, until yesterday, no problem. He went to sleep. He was fine. Today morning, doctor, when he woke up, there are bluish spots all over his body, right? So acute presentation. Yesterday night, he was fine. Today morning, all over the body, tiny spots, tiny bluish spots of hemorrhage, basically, right? So this is how it usually presents, acute form. Now, another important thing, guys, true, this is coming in the acute form, but what I want you all to know, often, write this down, often spontaneous remission. It heals often by itself, guys. It heals often by itself and doesn't usually, most of the time, guys, less than 2 months. It doesn't last long. It doesn't last long, right? In the adult one, we will see sometimes 6 years, sometimes 6 months, sometimes 1 year, right? It can go on for a long period of time, right? So we'll look at the adult form, guys. Adult form next. In adults, how does it come? This is the one we are focused on in internal medicine, right? This one, the peak is, guys, 20 to usually teenagehood, let's say 18 to about 50 years at this age, right? 18 to about 50 years. Now, autoimmune condition. Who is affected more? Who is affected more? Yes.
Females.
Females of reproductive age. This disease is much more common in females than in males, right? Because of autoimmune nature, right? Okay, what to do? No, so unfair, right? Right. Then the next thing. Again, what did we say, guys? Mainly here for ITP, right? ITP. This is mainly a platelet disorder. This is a platelet disorder, not a clotting factor problem. If it's a platelet disorder, what did we say? Superficial bleeds, superficial bleeding, right? Superficial bleeding. So, for example, right here, guys, just write this down. We have 3 types, petechiae, right? And then purpura. Put this as a side note, Put this as a side note. Petechiae, purpura, and the last one, ecchymosis. Ecchymosis. In ITP, what do we see? Petechiae or purpura. This is what we see. We don't usually see ecchymosis because it's superficial, unless, of course, it's severe. Unless it's severe, right? But ecchymosis is mostly seen in clotting factor problem. Clotting factor problem. So here, guys, this petechiae, purpura, why I wrote it like this, the size difference. Petechiae is the smallest. Then you have purpura, and then ecchymosis is the largest. Petechiae, guys, the bleeding spots, they are less than 3 millimeters in size, right? Very tiny, very tiny. We call this, another name is pinpoint bleeding. Pinpoint bleeding for petechiae, right? Purpura is about 4 to 10 millimeters, right? Anywhere in that range, and ecchymosis is greater than the 10 millimeter or greater than 1 centimeter in size, right? So usually for ITP, we see these, petechiae or purpura, right? And superficial, when we say superficial, guys, specifically the skin, you can see spotting on the skin, right? And sometimes some gum bleeding, and sometimes even, guys, if it's a little bit more serious, nasal, right? We call this epistaxis. Nasal bleeding, right? Nosebleeds, right? And, guys, another important point in your history taking, right? Specifically female patients, right? They will complain of prolonged menstrual bleeding cycles, right? Menorrhagia, right? Recent onset, right? Prolonged menstrual bleeding, right? Menorrhagia, and large volume as well, usually greater than 80 milliliters. No, that's what we say, right? Okay. So major bleedings, guys, this is very rare. Major bleedings, especially like gastrointestinal bleedings or intracranial hemorrhages, these are rare. They can happen, but they're rare. Okay, can happen, but they're rare. And what did we say about the adult form? This is mainly, guys, subacute, or we say it's chronic, right? Subacute or chronic. So it is a progressive disease, guys. Slowly. It doesn't happen overnight. Overnight, the patient doesn't notice spotting around his feet or hands, right? This happens progressively, right? Little by little, he will notice it. So physical examination is almost always normal, guys. Almost always normal physical examination, right? You won't see anything most of the time, right? And usually it is not like the acute form in children, it's not spontaneously remitting. So it stays on for 5 months, 6 months, sometimes 1 year, right? It stays on for a long time, right? Sometimes 5 to 6 months or sometimes a year, right? Then, guys, the other important thing is when it comes to the adults, you can look for some other diseases, not things like measles, not things like what we discussed, right? Not like chickenpox, right? There is usually no history of infection like that, but you can look for other associations. What are those? Other autoimmune disorders, guys. One is SLE, right? If they have SLE, highly likely that they can develop this as well, right? Then another one, HIV, right? HIV, right? And then hepatitis, right? Look for these. These are some secondary causes. And then thyroid disorders, right? For autoimmune thyroiditis, right? Thyroid problems, especially these autoimmune ones, right? If they have a history of these, there is a chance it might be ITP, right? Now, why am I saying like this, guys? We look for these things. We try to find these things. Why? ITP, write this down. Write this down in gold. The diagnosis, this is a diagnosis, right, of exclusion. There is no gold standard one test that you can do to diagnose ITP. Only thing you can see in the blood report, platelet counts will be low, right? Apart from that, everything, guys, you have to exclude other causes in order to diagnose this, right? Okay. So what are the lab tests we can do here? Obviously, we can look at a blood count. Now tell me this. I'm going to put the things, the absolute platelet count, right? You all tell me what is happening in ITP, right? Absolute platelet count, bleeding time, right? Prothrombin time, APTT, activate partial thromboplastin time, and even thrombin time. What will happen? Tell me this absolute platelet count. What happens in ITP? Reduce. Very easy, no? Right. Okay, we'll start off with prothrombin time. What happens in ITP?
Increase.
Prothrombin time and APTT. What do they measure? What does PT measure? Tell me. Plate tennis.
Remains same.
Plate tennis outside. Extrinsic pathway. APTT. Plate table tennis inside. Right? Intrinsic pathway. What are extrinsic pathways and intrinsic pathways of platelet issues or clotting factor issues? What?
Clotting
factor.
Clotting factors, right? There is no platelet involvement there. So if you have ITP, these will be normal, all normal except bleeding time. Why? When there is a platelet issue, what happens? Can we form the platelet plug? No. So bleeding time will be high. Did everyone understand? If you all did not understand this, learning the physiology was pointless. Did everyone understand this? Very important. This is the most important part of today's class, right? This is how you get the questions. They will tell you this patient had this. These are the manifestations. Bleeding time high, PT, APTT normal. What is the most likely diagnosis? ITP, right? Give me a thumbs up if you all understood this. No thumbs up. I see one thumb up. Okay, 2, 3. Okay. All right. Okay. Right. If you all have any question about this, drop me a message after the class. Very important part of today's class. Then, guys, so that's the first lab test we can do, right? Second thing, guys, we can look for platelet autoantibodies, specifically autoantibodies against glycoprotein 2B3A. Now, here's the important thing, guys. This one only 60 to 70% of patients will show. Some patients, guys, you will not see it. You will not be able to catch these autoantibodies in the sample, about 20 to 30% of the patients, right? That is why we cannot put these as an essential item in the diagnosis. We cannot call this the gold standard. That's why this is a diagnosis of exclusion, right? Platelet autoantibodies. Next thing, guys, we can look at a platelets. We can look at a blood smear under the microscope. When we look at the blood smear, guys, what will we see? This part is important. Now, what is happening? All platelets are being destroyed, right? Platelets are being destroyed by the spleen because the autoantibodies have come and bound to them. Now they are more attractive to the splenic macrophages. They are being destroyed. So in compensation, what is our, now remember we talked about in our hemolysis chapters, when RBCs were destroyed, what happens in compensation? What happens in compensation? What does our bone marrow try to do?
Produce more.
Produce more RBCs. So in the blood smear, what will you see? In a case of hemolysis, what did we say? Reticulocytes, immature RBCs, right? They increase. Same concept applied here. Thrombocytes or platelets are being destroyed. So what is going to happen, guys? Bone marrow is going to try and compensate. So mature platelets will be less. Immature platelets increase in the smear. You will see them. These are, guys, just like RBCs. These are much larger. Right? We call these mega thrombocytes, right? You will see very large platelets in the blood smear, right? Okay. Right. Okay. So these are the main diagnostics, guys. Just put note, right? We have some notes here, right? Write this down. These are important for your clinicals, because in the Vivas, they tend to ask, guys, diagnostics is, look at the platelets, right? See if you can find antibodies, do the blood smear. Then there are some extra points, especially in your Vivas, you can tell if your patient is greater than 65 years old, right? If the patient is greater than 65 years old, it's better to do a bone marrow biopsy. Why? We want to try and exclude, right, malignancies, right? Okay. This is the main reason why we do it. Another thing that the bone marrow biopsy can help us with, right? What do you think? Now, remember we talked about in hemolytic anemias, when the bone marrow is trying to compensate, in the bone marrow biopsy, what will you see? 1 week ago, we learned.
Mature blood cell.
Sorry, I did not hear you, Shani.
Immature blood cell after the hemolysis.
Immature red blood cells, you will see it in the blood. In the bone marrow biopsy, what will we see?
Erythroid hyperplasia.
Erythroid hyperplasia. The erythroid cell lineage will be hyperplastic, right? Now think the same for this. When there is platelets being destroyed and the bone marrow is trying to compensate, the megakaryocyte lineage, hyperplasia, right? It increases in number, right? That will further help you confirm a diagnosis of the ITP. It's not diagnostic, but it will help you come into the diagnosis. Okay. Main reason to do biopsy is if they are 65 greater than 65 years old, to exclude a malignancy. Okay. Then, guys, another important note, especially on physical examination, what did we say? ITP, majority of the patients normal. You won't see anything, right? Because it is an insidious onset. It is a progressive disease. On the physical examination, you palpate the stomach area, right? And you feel the spleen is a little bit enlarged, right? What might that indicate? Remember, under the causes, we talked one important cause at last, hypersplenism, right? This is a different cause, right? Increased spleen function. So what can we do in that? Sorry, if you do the physical examination, feel that the spleen is a little bit enlarged, to confirm, you can do an abdominal ultrasound scan, right? This is why to rule out hypersplenism. Okay, to rule out hypersplenism, right? Then the last one, guys, especially based on the history, right? Based on the patient's history, you can do HIV or hepatitis testing. Hepatitis testing. That is based on the patient's history, guys. Okay. If they are IV drug users, multiple sexual partners, right? These kinds of things, you can test these as well, right? To rule out the secondary causes, right? Okay. So these are some extra points, extra points, especially for your vivas. Okay. Then we'll come to the treatment. How do we treat this? How do we treat this? Look at this, guys. We have some first line treatments and some second line. First line therapeutics. What can we do? Here, guys, very important. ITP, what did we say? Usually the adult form, these are very mild. We don't usually see even ecchymosis, right? It's not a big problem. So if you check the patient's platelet count, if the absolute platelet count is greater than 30,000, 30K, greater than, now normal range is what? 150K to 450K, 150,000 to 450,000. If it is greater than 30,000, guys, usually no need treatment. Usually no need treatment. Okay, right? Unless they are going into a surgery, right? Or they have a biopsy procedure tomorrow. If something like that is there, then you can give prophylactic drugs. We'll talk about that later. But without that, normal day-to-day life, no need treatment, right? Because this is stable, compensated most of the time, right? Next one, if their platelet count, right? If it is less than 30K, right? And if it is greater than 10, that means what? 10,000 to 30,000 in this range, 10,000 to 30,000 range. In this range, guys, it's a little bit more serious. So we can start them on oral corticosteroids, right? Oral corticosteroids, right? Usually something like hexilon, methylprednisolone, right? Dexamethasone, things like that, right? No need to know the doses for MBBS here, no, right? Methylprednisolone or dexamethasone, right? What do these corticosteroids, how does this help, guys? How does this corticosteroid help? Why are we giving this in this from ITP?
Anti-inflammatory.
Okay, and more than that.
Immune functions will be reduced.
Yes, that's the main thing. Immune suppression. Immune suppression. This is an autoimmune disease. This is why we are giving this. Immune suppression. This is one of the main things. Then, yes, the second one, Tarinda, what you said is also correct. Anti-inflammatory. Write this down, guys. Immune suppression effect of corticosteroids takes a little bit time to develop. Even before that, right? These corticosteroids, we say they help to increase what we call vascular tone. Vascular tone increase. What do we mean by this, guys? They help or they stimulate substances that promote. They help to stimulate substances that promote vasoconstriction. Vasoconstriction. Right? Thereby reducing bleeding. Right? So for example, endothelin. Do you all remember endothelin we talked about? Oral corticosteroids in general, they have the ability to stimulate the release of endothelin from vascular endothelial cells. Right? So vascular tone increases, therefore vascular stability increases. So bleeding tendency reduces. Immune suppression effect is the major player, but that comes in a little bit of time. Right? Okay. Right. Then, guys, rarely, what did we say? Very rarely, this can be a little bit serious. That means what? Platelet count, right? Platelet count less than 10,000. Now, this is quite serious, right? Less than 10K. If this happens, guys, highly likely in the clinical picture, it will have gastrointestinal bleeding, intracranial hemorrhage, things like this will be there, right? Spontaneous bleeding. Right? In this case, guys, how can we treat this? Here we go with IV drugs, IV methylprednisolone, right? IV, because we want the effects to come fast. The second one is, guys, intravenous immunoglobulins, IVIG, immunoglobulin, right? Simple G, no? IVIG, immunoglobulins. Now, what does this do? But there's IV methylprednisolone, you all know, it's a corticosteroid. How it functions, now we know. IVIG, intravenous immunoglobulin. How does this work? How does this work? Huh?
Explain
These
what
antibodies against the
Antibodies against the antibodies. Is that what you're thinking?
yeah.
No. No. Any other answer? Tarinda, what did you say?
splenic macrophages might engulf that thing instead of the.
You touched on it and then you went away. Okay, let's look at this. Look at this, guys. IVIG, it's okay. I mean, you all have to come up with hypothesis and then we'll see how it works, right? Good. You all are thinking. Here, what happens is, guys, remember we said in the spleen, the splenic macrophages, right? These guys had what? Specific receptors for the FC portion of the autoantibodies. That's how they captured the platelets. No, the platelets became more attractive to them and they captured them. Remember? Now what happens when you give IVIGs? These immunoglobulins will go and bind to these. They will go and bind and block these receptors, right? Now what do you think? Can the splenic macrophages capture those platelets? No, they cannot capture the platelets. Therefore, what happens? So you all can write this. What are these guys? They bind to and inhibit, right? Receptors of reticuloendothelial macrophages, basically splenic macrophages, right? Okay, this is what they do, right? Right. Clear. Then the last thing there, guys, another thing we can do when the platelets are very low is platelet transfusion. Now I know students in China have experienced going and donating platelets a lot, right? Yeah, right. Don't worry, we've all been there, right? Even myself, right? Fun times, right? Okay, so platelet transfusion, that's a good act, good thing you all are doing. But yeah, I know why some people are doing it also, right? Besides the, let's move on, right? Platelet transfusion, right? What happens, guys? This one, what can you do? This one is reserved. This one is reserved for very severe cases. Very severe cases. Very severe. Why? Tell me this. Why is this a platelet? Now this is a problem with platelets, right? There are platelets being destroyed. Why is this reserved for very severe? Why don't we just give platelets? This is a platelet problem. Why don't we just give platelets to a patient who has ITP?
Constant transfusions will be required. Like since the half-life is very short. Sorry, the lifespan is very short.
Okay. Lifespan, let's say 10 days, right? So why cannot we do a transfusion every 10 days? It's inconvenience.
Yes.
Sorry, Shaheen, what did you say?
To prevent serum sickness.
To prevent? I'm sorry, I cannot hear you clearly.
The serum sickness.
Serum sickness. Okay.
DIC?
DIC. No, DIC won't happen here because now anyway the patient's platelet is less than 10,000, right? Platelets are less than 10,000. So if you give platelets, no issue like that. Why we are not giving, guys? This is an autoimmune condition. What is there in the patient's serum? What do they have? Antibodies against platelets. So if you give platelets, what will happen? Again, they will be destroyed. No matter how much you give the patient, because we are not correcting the underlying cause. The underlying cause is an autoimmune condition, right? So that's why this is reserved for very, very severe cases, because whatever you give will also be destroyed. But this is better than nothing in a very, very severe case. Better than nothing, right? We are giving it because we have no other option, right? Better than nothing, but pretty much whatever you give will be destroyed as well. Okay. Right. So these are the first line things. Then look at the second line, right? Second line. What are the second line treatments for ITP? right? Second line once. Look here, guys. The next line we can go for, especially if the first line is not functional enough, we can go with specific immunosuppressor agents. Immunosuppressor agents. For example, azathioprine, right? Azathioprine, cyclophosphamide, right? These kinds of medications, right? Right? We don't usually want to do this. Why? ITP is not very serious, but in the case that the first line is not working and the disease is a little bit more serious, we can go with this. Now you all should understand immunosuppression comes with side effects, right? Their susceptibility to other infections will increase, right? Second one is, guys, these MABs, monoclonal antibodies, rituximab. What is this? This rituximab, guys, write this down. Does anyone know how this works? How does rituximab work? Anyone? Right. Rituximab, guys, this is an anti-CD20 agent. Anti-CD20 agent. This CD20, which cells have CD20 in majority, guys? Which cells? B cells or T cells? Excellent. Right, good. By the way you responded, I'm assuming it's a guess. Yeah, this is on B cell surface, right? B cell surface, right? These are majorly present on B cell surface, right? Basically, these are the surface antigens on B cells, right? So what will happen, guys? This rituximab will come and bind to these CD20 agents and they will block them on both, works on both normal or healthy B cells and pathogenic B cells. Pathogenic B cells, right? They bind to both. Right? So we primarily want the pathogenic one to be bound, but they cannot selectively bind like that, right? So overall, there will be autoantibody production, right? Autoantibody production will be dropped, right? This is how it basically works. The mechanisms are very deep, but we don't need to talk about this too, right? Right. Then another agent. Now, do you all remember, guys? For RBC production, when we talked about iron deficiency anemia and these chapters, right? For red blood cell production, there was a specific hormone that stimulated the production of these. Do you all remember that hormone that stimulates? Erythropoietin, right? Like that, from the kidney and some part from the liver, right? There is a hormone that stimulates the production of platelets. What do you think this is called?
Thrombopoietin.
Excellent. Thrombopoietin. So this thrombopoietin, guys, we can give it via injection to the patient, right? Basically, what we give a thrombopoietin receptor agonist. This is what we give, a thrombopoietin receptor agonist, right? So what will this do? It will reverse thrombocytopenia. It will try to at least reverse thrombocytopenia by the facilitation of thrombopoiesis, right? Okay, so this is another word that we can use for this is, guys, platelet growth factor. This is another name they use for this, same thing, platelet growth factor. Okay, right? And the final thing we can do if nothing works, right? Last option, you can put it in black person. Final option, splenectomy, right? Splenectomy. Okay. Now in ITP, usually do we have splenomegaly in ITP? Do we have splenomegaly? No, in the physical examination, we said majority, 99% of the cases, physical examination is normal. So ITP is one of the places, guys, especially if severe, even though the patient doesn't have splenomegaly, we remove the spleen, right? This is one of those medical exceptions. Okay. All right. right? Splenectomy. Now, just put a note, guys, a variation of ITP. This is students who are writing USMLE. You have to know this. This is not there in CLAB, BRPM, even MCI, I don't think so, right? If it's there, let me know. In USMLE, yes, yes. There is a variation of this, guys, called, write this down, Glanzmann thrombocytopenia, right? Glanzmann thrombocytopenia. What is this, guys? Now, this one is not an autoimmune thing, right? This also falls under ITP, but what happens here? This is an autosomal recessive genetic defect, right? This is a genetic defect that causes defective receptor 2A GP, glycoprotein 2A 3B, right? An autosomal recessive defect in the glycoprotein 2B3A. Sorry, my bad. 2B3A, right? Okay, right? Glycoprotein 2B3A, right? Okay, so this is another variation. Yeah, right? Then, guys, just another note, but this is not related to ITP. Just put it. So this was note number 1. Note number 2, guys, just write down. There is another disorder. Again, USMLE. If you're writing, you have to know this, right? They tend to ask these things, right? Another disease called, write this down, Bernard Solier, right? Syndrome. Bernard Solier syndrome. This is another autosomal recessive defect, but this time the defect is in glycoprotein 1B. If there is defective glycoprotein 1B, what happens? Tell me. What happens? What happens?
Platelet adhesion.
Platelet adhesion. Adhesion to 1 milliband factor is lost, right? Okay. Here what happens? For the 2B3A, aggregation. Aggregation is lost, right? So these two, if you are writing USMLE, yeah, right? Just know these two. Okay. Manifestations will be similar, guys. Clinical picture will be similar. Clinical picture is similar. Just that the cause is an autosomal recessive genetic cause. Okay. Right. So that's about it for ITP. Then we come to TTP. What is this? Thrombocytopenic purpura. Okay. Thrombocytopenic purpura. Right. This one, guys, this is much more rare than ITP. ITP is way more common than TTP. Okay. About 1 in 750,000 people will have this disease, right? It's not common, right? It's rare. But again, this one also, if we look at the causes, guys, look at the causes of TTP. The major cause, the most common cause, it's a rare disease, but out of that rarity, the most common cause is an autoimmune condition. Autoimmune condition. About 90% cases of TTP will be autoimmune, right? Look at this. This is an antibody against ADAM, TS13. Now tell me what happens. What happens? What happens? What is ADAM TS13? What did it do? What does ADAM TS13 do?
Comes from the liver and breaks down the multimers of
Yes. Wait.
one that thing.
Yeah,
VWF.
exactly.
Von Willebrand factor. It breaks it down.
Yes.
Multimers.
Yes. Basically cleaves the von Willebrand factor multimers into more functional, right, and efficient von Willebrand factors, right? This is what it does. Now what do we have? We have antibodies against ADAM, right? Antibodies have come and bound to ADAM, right? Therefore, what do you think? Can it cleave the von Willebrand multimers? No. Von Willebrand multimers not cleaved, right? So what happens, guys? Von Willebrand multimers now start accumulating. They start accumulating, right? Von Willebrand multimers accumulating. Now, tell me this, guys. When von Willebrands are like this, right? What do you think if they form platelet aggregations? Will they be tiny platelet aggregations or very large, huge platelet aggregations? What do you all think?
Huge.
Very large, huge, right? So the platelet adhesions and the aggregations, right, will be very large. So they will form large thrombi form, right? Okay. So especially, guys, right? Here, when they are forming large thrombi, to form large thrombi, do we need a small number of platelets or a large number of platelets? What do you think? I'm asking very simple questions. Large number. So to form large thrombi, what will happen? Large number of, write this down, large number of platelets are being used up, right? Used up. Okay. So in their blood, if you look at their blood sample, right? Their platelet will be low. Platelet counts will be low. This is why this TTP falls under thrombocytopenia, right? Platelet counts low. At the same time, what are they doing? They are forming large thrombi. So especially, guys, in microvasculature, you all know in our tiny blood vessels, they can almost obstruct them, right? Our tiny blood vessels will almost be obstructed. Specifically, guys, write this down. Renal blood vessels, renal arteries, right? And our cerebral blood vessels will be obstructed. Cerebral blood vessels can be obstructed, right? Now, look at this, guys. These large thrombi. Let's take a look at one of these microvasculatures. Let's say this is a microvasculature, right? Now, what has happened due to this ADAMTS13 mutation, right? The von Willebrand monomers are not, von Willebrand multimers are not broken down. So they will be here like this, large multimers, right? Large multimers like that. And therefore, they will form clots, right? As platelets come and aggregate, right? They will form large clots, right? Obstructing almost the entire vessel, right? Now look at this, guys. Once these platelet plugs, large platelet plugs are formed like this, right? We know, especially in arteries are a high pressure system, right? Correct? Arteries are a high pressure system, right? And RBCs are continuously flowing, guys. RBCs are continuously flowing. Now what happens, guys? RBCs have to go through these very tiny pathways, right? And to come out of the other side, and most of them will be even obstructed. As they travel like this, squeezing through these tiny gaps, right? That was obstructed by these platelet plugs. What happens, guys? They get destroyed. RBCs start breaking down, right? Okay. Because of this thrombi that are obstructing, especially these microvasculature, right? So therefore, why are these RBCs breaking down, guys? These platelet aggregation plus the fibrins, these are toxic, guys. These are toxic when they are unnecessarily large, right? They become toxic for red blood cells. At the same time, in arteries, what do you think about the pressure of the blood flow? This is a high pressure system, high blood pressure. So both of these reasons, what happens, guys, right? There is going to be what we call fragmentation of RBCs, right? This is what we call, guys, a helmet cell. Helmet cell. Or the medical term for this is schistocyte. Schistocyte, right? Schistocyte. So if you do the blood smear, you can see the schistocytes. I think I have put a picture. Right. Look at these guys. Look at these RBCs. These are schistocytes, right? Abnormal shape, destroyed, right? Fragmented. They have lost their nice biconcavity, right? Central pala and all are gone, right? Just destroyed. This is what you can see, right? Okay. So that was the first cause, guys. The first cause, right? An autoimmune condition. Then rarely, guys, this rarely about 10% of the cases can be a genetic disorder of Adam TS13 mutation, right? That one we are not going to talk about. That is very, very rare, right? Even more rare, right? Autoimmune is the main cause here, right? Now, look at this. Now, here's an important thing. This, because of this pathophysiology that we discussed, now there is going to be a nice clinical pentad, what we call a clinical pentad. Write this down. Write this down. All right. Here, guys, first thing, because the platelet number is low, they will manifest with purpura or sometimes petechia as well. Why? Platelet count is low, right? Platelet count is low. Then, when their blood vessels are obstructed, specifically the microcirculation, one thing, they can have acute, when the renal vessels are obstructed, renal impairment. Now, if there is acute renal impairment in the blood reports, what are you looking for? What can you look for? The patient's blood. Tell. Doctors think.
Serum creatinine.
Excellent. Serum creatinine will be high. Serum creatinine will be high, right? Serum creatinine will be high. Next one, guys, if their cerebral vasculature is obstructed, they can show cerebral dysfunction, right? Confusion, not very serious issues, guys, right? But recurrent confusions, right? Loss of memory, things like that. Not too serious, but occasionally they will show, right? Then, guys, the next one is this. MAHA. What is this? Microangiopathic hemolytic anemia. Why microangiopathy? Why? Especially in small vasculature, in small vessels. Hemolytic anemia, why? This fragmentation of the RBCs, right? Microangiopathic hemolytic anemia, right? So here, what will they show? One thing you all already know, schistocytes or Hilbert cells. You all already know. Hemolytic anemia in a blood report, yes, we can see hemoglobin problems. Anything else we can see, especially when there is intravascular hemolysis?
Undetectable haptoglobin.
Okay, yes, true. That those will be there. Apart from that, a very common test that we can just do with the normal blood reports, LDH. Remember we talked about when there is hemolysis, when red blood cells are being destroyed, we talked about in the last session, lactate dehydrogenase released. So in their blood, what will you see? LDH high. LDH high. These are very simple tests. True, guys. There are a lot more other tests we can do. They're just simple tests for the diagnosis. Another one, clinically, hemolytic anemia. What do you see? Clinical picture.
Hemoglobin urea.
Pallor.
Very deep things.
Pallor.
Pallor, yes. One more specific one. Pallor can happen due to a lot of reasons. A little bit more specific, not too specific. A little bit more specific. What do you say? Jaundice, icterus, right? We said for hemolysis, the jaundice is not too severe. We discussed all of these. I hope you all remember. So here you can see icterus, right? Icterus, right? Simple things, right? Microangiopathic hemolytic anemia, and all of these, guys, why we put this pentad commonly accompanied by fever. Commonly, this is right. It's not very specific, but usually these patients come with fever, right? Okay, right. So this pentad is the clinical pentad of TTP, right? Those days there was only a triad. Now they've increased it to a pentad. Okay. because we see these more commonly now. Those days it was only purpura, fever, and MAHA. They didn't put the renal impairment and cerebral dysfunction. Now that is also included because we see it commonly, right? This is the clinical pentad of TTP. Yeah. Right. How do we treat this? How do we treat this? Alex, what do we do? Here, guys, nothing much we can do, right? This one is a much rarer disease, but if a patient has it, it's a little bit more. It's not a little bit, it's quite fatal, right? It's quite fatal. We'll talk about it. The treatments, guys, we only have two: emergency plasmapheresis. Plasmapheresis. What does that mean? Transfuse plasma, right? Take plasma from another person and exchange it with the patient's one, right? Emergency plasmapheresis. And the third, next one is IV corticosteroids. Corticosteroids, right? IV corticosteroids. These are pretty much our only options here, right? Just write this down, guys. Even with successful treatment, right? The 6-month mortality rate, right? Mortality rate is between 30 to 40%. See how severe this is, right? Most of the patients, if they get TTP, right, they're going to die, right? It's very difficult to manage, right? And even if you successfully manage it, within the next 6 months, they are highly likely to develop other complications, right? That's the nature of this disease, right? Okay. Why? Look at this pentad, guys. Forget the fever and the purpura. All the other three are very severe and very difficult to manage. Cerebral dysfunction, when cerebral blood flow is cut off, huge issues, right? Renal impairment, right? Toxins will keep building up, difficult to reverse, right? And it's acute. It's not like a chronic renal failure. They acutely go, right? And the MAHA, hemolytic anemia, they're losing red blood cells also, right? So very difficult to manage all three when they're together. Okay.
Prashan,
Yes.
since it's autoimmune, won't it affect children as well? I mean, is it in grown-ups or children?
No, commonly we see it in adults. We don't usually see this in children. It's not associated a lot with children. ITP, yes. But TTP is mostly in adult females. Again, adult females. Huh? But again, this is a very rare disorder. That's why we said at the start, 1 in 750,000 people, right? Quite rare. Okay. Rare but fatal. Huh? Then we come to the final topic of today, guys. Drug-induced thrombocytopenia. We are mainly talking about heparin-induced thrombocytopenia. Many drugs can cause thrombocytopenia, guys, right? But we are not going to discuss those. For our MBBS, we need to learn how heparin, right, can cause thrombocytopenia, right? It's actually a very painfully annoying problem. Why? Heparin is what, guys? What is heparin? What do you all know about heparin? What is heparin? What is heparin? What do you all think? What is heparin, guys?
Anticoagulant.
It's an anticoagulant. Anticoagulant, right? It's an anticoagulant. So why do we usually give it? To try and reduce clot formation, especially in a patient who is already having a lot of clots, right? We tend to give heparin, right? So ideally, we would want it to go and stop the clot formation. But as we will see in the mechanism, guys, when in some patients, this does not happen in everyone. In some patients, when we give heparin, right, it actually worsens the situation, right? It goes and causes further reduction of platelets, right? And thereby causing more serious problems. We'll see what is going to happen, right? Look at this. First thing I want you all to know, heparin is an anticoagulant, as you all said. And the important thing, it is destroyed by stomach acids, right? So can we give oral? Can we give heparin oral to anyone? No. Why? Destroyed by stomach acids. So this one, guys, usually we give it as a subcutaneous subcutaneous injection, right? Subcutaneous injection, heparin, right? Under normal scenarios. Now, what is the normal function of heparin? First, we'll understand that. Normal function of heparin. When we give heparin, guys, what happens? Heparin, the mechanism of action, there are mainly one way, but there is a supplementary pathway as well. The major way that heparin works in our body, right? First step, this goes and binds to antithrombin 3. Antithrombin 3, right? Heparin goes and binds to antithrombin 3. Next, what happens is, guys, there is a conformational change. Conformational change in the structure of antithrombin 3. And that results in a very, very high increase in the function, right? It goes and results in a very increase in the activity of antithrombin 3, right? Nearly, guys, if you read your textbooks, they will say nearly 1,000-fold increase. Nearly 1,000-fold increase in the activity of antithrombin 3, right? Now, if you all remember, tell me, what did antithrombin 3 do? What exact ones did it work on? Clotting factors?
NA.
Excellent. What's the other one? A little bit of 2A as well. It goes and inhibits these. It goes and inhibits these, right? This was what antithrombin 3 did. We drew it like a mouth, like a scissor, right? It went and ate those up, right? Now, here's the important thing I want you all to know, guys, right? Heparin, for the inhibition function of this 10A and 2A, right? We need for the 10A, for the 10A short chains, I know, short chains of heparin, right? And for the 2A inhibition, we need long chains, right, of heparin. Okay? Keep this written down now. I will tell you what is the clinical importance of that, the long chain, short chain story. But now I want you all to know, what does heparin do? Goes and 10,000 times increases the function of antithrombin 3, right? Okay, right. We come to the next part. When we talk about heparin, guys, in clinical use, we have two forms. One is called unfractured heparin, UFH, unfractured heparin. The other one is what we call low molecular weight heparin. Low molecular weight heparin. Now look at this. Just by these names, which one do you think has long chains? The structure. Unfractured, guys, it has long polysaccharide chains in their structure, right? Long polysaccharide chains, often 20 to 30 polysaccharides. Low molecular weight heparin, guys, this is less than 18 polysaccharides in their structure, right? In their structure. Now we'll take a small comparison here. Unfractured heparin versus low molecular weight heparin. First one, the size. If you look at the size, unfractured heparin is obviously large, right? Large, 20 to 30 polysaccharides. Low molecular weight heparin is small, right? Less than 18, right? Less than 18. Now, when we look at the half-life, these are therapeutic drugs. So we talk about the T-half or the half-life. Unfractured heparin, guys, right? It has a half-life of about 1 hour, right? Whereas low molecular weight heparin has a much larger one, about 4 hours, Okay. Now, just on the basis of how many now what did we say about heparin? Heparin cannot be taken oral, right? Always subcutaneous injection. So just based on that fact, which one do you think is more convenient? Unfractured or low molecular weight? Just based on the half-life? Yeah, low molecular weight. Why? Unfractured, if you are giving how many injections a day, right? Every 1 hour you have to give, right? So just based on that, right? We'll keep going, right? Then, if you look at the bioavailability, right, of the drug, right? Unfractured heparin, half-life is shorter, so bioavailability is less. Low molecular weight heparin, bioavailability is high, right? Okay. Now, the next one, guys. If you look at renal excretion of the drug, now, unfractured heparin versus low molecular weight heparin, based on the size, what do you think? Who is excreted readily from the urinary system?
Low
Low molecular.
Low molecular weight heparin. This is excellently, very easily excreted, whereas unfractured is poorly excreted from the renal system. It is broken down into, yes, difference, guys. Unfractured heparin can be broken down in our body to low molecular weight heparin and then excreted, right? But the renal excretion is poor, right? Okay. Then, guys, now tell me this. If the renal excretion is poor in unfractured heparin, think carefully, and the renal excretion is very good in low molecular weight heparin, for a renally impaired patient, which one is the better drug?
Unfractured.
Why?
Yeah.
Why?
Because it doesn't need to filter anymore. So the work is
Excellent.
just-
Excellent. This low molecular weight heparin, guys, this is good. As we discussed, they have a larger T half, their bioavailability is high, it's good. But if the patient is renally impaired, right, this low molecular weight heparin poses a disadvantage, right? Okay, because it cannot be excreted and it will start building up. Right? Okay, then guys, we have to talk about, because these are anticoagulant agents, right? We have to talk about the antidote for them. Antidote, for example, if you give a patient too much of heparin, what should you do? The antidote for heparin is what, guys? Anyone knows? Huh? What is the antidote for heparin? Have you all heard of protamine sulfate? This one you should know, guys, for your vivas. You should know. Antidote for heparin is protamine sulfate, right? Here's the thing, guys. Unfractured heparin, right, is very well reversed by protamine sulfate. So you can, without any fear, you can give it, right? True that its T half is short, bioavailability is less, but you don't have a fear of it being overloaded in the patient. Even if it goes, you can give protamine sulfate, good response, it will be reversed. Low molecular weight heparin, guys, this one, partial reversal, only a partial reversal. So if you go overdose, there can be issues. Its activity is good, T half is good, bioavailability is good, right? But if you go overdose, it's a bit difficult to reverse, right? Okay. Now, based on this table, based on the things that we have talked about, what do you think is now these are anticoagulants, right? What do you think is the current drug of choice for what we call thromboprophylaxis? Prophylaxis, especially, guys, if a patient, we've talked about this in cardiology modules, right? Long time ago, right? If they're having, right? If they have had a myocardial infarction, if they have had a stroke, we put them on what we call thromboprophylaxis, prophylactic drugs to try and prevent them from having strokes or myocardial infarctions, things like that. So for emergency thromboprophylaxis, which one do you think is the better option? Huh? Unfractured or low molecular weight? What do you all think? Huh? What will you all go with? As an experienced physician, which one will you all go with? Huh? What do you think? Which one has more advantages? Which one has more advantages?
Low molecule.
Low molecular weight, guys. True, the risk is a little bit high. That's why I said as an experienced physician, right? Okay. Right? True, the risk is a little bit more, but the drug of choice, guys, is low molecular weight heparin. The most common one you might have heard, enoxaparin. Enoxaparin. This is the one that we use now. Enoxaparin. Subcut, subcutaneous injection. Right? Okay. This one I just wanted to teach you all guys without just teaching heparin-induced thrombocytopenia, just some basic facts about heparin, which you all should know as medical students. Right? Now we'll come to the HIT. Right? Now we'll come to the HIT. Heparin-induced thrombocytopenia. Right? Nothing much here, guys. Look at this. Here, what is the mechanism? Remember, guys, we said platelets, once they are activated platelets produce and release several things. One of them were the granules, and we talked about some alpha granules and some delta granules, right? I hope you all remember. In the alpha, guys, if you all remember, I said there is something released called platelet factor 4. Now, this is where this heparin-induced toxicity or thrombocytopenia comes to play. Platelet factor 4, guys, is a very special thing. Look at this. Platelet factor 4 that is released as an alpha granule, right? It has the ability to go and stimulate surrounding platelets. That is one function. The next function is, guys, platelets, we said, have multiple receptors. Platelets themselves have this receptor for platelet factor 4. So true, they can go and stimulate surrounding platelets to be activated. At the same time, platelet factor 4 can get self-stimulated, right? They can self-stimulate the platelet to be even more active, right? Self-stimulate. This is a property of this platelet factor 4, right? Okay, right? Now, look at this. Let's say, so now I have a platelet that has been activated, right? Okay, and his platelet factor 4 has been there. Now, what did we say was the normal function of heparin, guys? Heparin is able to increase the function of antithrombin 3. Okay? Increase the function of antithrombin 3, thereby inhibit 2A and 10A. 2A and 10A. One question. What do you think? When you give low molecular weight heparin, which is our drug of choice, which one is inhibited more, 2A or 10A? Go a little up and think and tell me.
10A.
This is why I said this, right? Right? Remember, we talked about shorter chains can effectively, right, inhibit the 10A. So who has shorter chains? Low molecular weight heparin. Low molecular weight heparin, right? Now look at this case. Now let's say we gave heparin to this patient, right? Due to some reason, he was prescribed heparin and you gave heparin, right? What happens, guys? This heparin will come and bind to this. Let me draw this again. You all can also draw it. I can just copy and paste. Heparin, true, it does all those things. It goes and increases the function of antithrombin 3, inhibits 10A, inhibits 2A, true. It also comes and binds to these. What is this, guys? To this platelet factor 4. Heparin comes and binds to platelet factor 4 like this, right? Platelet factor 4. This is the problem. In some individuals, write this down. In some individuals, not everyone, guys. in some individuals, this complex, what do I mean by this complex? The platelet factor 4 and heparin complex. Platelet factor 4 heparin complex, PLTF4 heparin. This complex, in some individuals, this complex is immunogenic, right? It's immunogenic. What do we mean by that? It goes and stimulates the immune system to produce antibodies. We do not know why exactly this happens, right? We do not know, right? This happens in some patients, right? Okay, now what is going to happen, guys? Now, so IgGs will be produced in these patients. IgG against this complex will be produced, right? IgG against this complex. Now what will happen? IgG will come and bind to these complexes, right? Like this. Okay, look at this, guys. This is the special thing that happens here. When this happens, guys, right? Draw this like this. Need a bit more space. When this happens, right? This platelet goes nuts, right? This fellow, right? Okay, goes super crazy, right? What do I mean by that, guys? Now look, he has the antibody. I'm not going to draw all those structures again, right? You all can draw it in your free time. Just the auto antibodies I'm going to draw now. They have come and bound like this. What happens, guys? They get hyperactivated. And what's another thing? Due to these antibodies, guys, surrounding platelets, right, will come and bind, right? Surrounding platelets can come and bind to these with their receptors. I'm not going to draw a very nice picture. Eventually, what is going to happen? We call these guys, when we say platelets binding to platelets or platelets binding with each other, what's the word? What's the word?
Aggregate.
Aggregation. Now, in the case of this case, we said what? Hyperactivation. The word here, guys, in the textbooks, you all will see hyperaggregation. Hyperaggregation of platelets. Hyperaggregation of platelets. Now, look at this. Why did we give heparin to the patient? Why did we give heparin to the patient in the first place? He probably had some problem where he was forming a lot of clots. What happened? What happened? Problem doubled and tripled. He is going to form even more clots now. Hyperaggregation, right? Okay, right? So this is the issue, guys. What is going to happen? So these hyperaggregated platelets, guys, let me copy this somewhere here. These ones, right? These ones, let's draw a little bit of a like a mess there. They're going to form large accumulations like that. These ones, guys, right? You all can draw later, right? Just large accumulations, hyperaggregated platelets. These ones. So what is the first thing? One thing, large thrombi formation. Large thrombi formation, right? So thrombotic, right? Patient is now going into thrombosis. Another one, guys, when they are using up this much platelets, what happens? And when these large platelets aggregate like this and they are going through the circulation, right? Because there is not necessarily a 1 milliband factor to try to capture the platelets onto the endothelial cells, right? This is just circulating platelets. You gave some heparin. What is happening? They are starting to aggregate within the circulation. So eventually, what will happen? They will come to the spleen. In the spleen, these abnormally large ones. What happens? Whose favorite? Macrophages. Macrophages will start to eat them. So what happens? Platelets start dropping down. Right? Okay. Right? So what is happening, guys? You tried to give heparin to stop the patient from forming clots, right? Matter got much, much worse. They started clotting even more, right? And using up all their platelets now. Platelets are also going down, right? Now, Look at this, guys. Here is the, so this is the basic mechanism. This is the basic mechanism of how this works, right? Heparin-induced thrombocytopenia, right? Here the clinical, guys. Clinically, how do we see this usually? What do you think? Now, you had to give the heparin. The heparin had to bind with platelet factor 4, and that platelet factor 4 and the heparin, that structure, right? That one is the one that induced antibody production. Do you think this can happen in a day? Right? The stimulation of the immune system to produce a new antibody against this substance, can it happen in a day? No, usually, guys, production of an antibody like that after stimulation of the immune system takes quite a few days. It actually can take anywhere from 7 to 14 days. 7 to 14 days, right? 1 to 2 weeks, basically. So when do we see this in the patient? We see heparin-induced thrombocytopenia in a patient, right? Usually onset after 1 to 2 weeks of heparin administration. Heparin administration. So this is how it will come in your history, guys. The patient was admitted to the hospital for some other problem, maybe a mild case of DIC or something, right? And he was administered some heparin. He was fine. A week later, he started developing thrombocytopenia, right? Most likely cause HIT, right? Now, what if, listen carefully, what if you got a patient, he got heparin-induced thrombocytopenia this time, but you were a little bit of a careless doctor and you did not note this down in the patient's system, in the clinical record. You did not write that the patient had a reaction against heparin and developed thrombocytopenia. After a year, the patient comes again for a similar issue. He needs heparin. You're not working in that hospital anymore. The doctors in that hospital don't know that he has had a reaction like this before. They give the patient heparin. Now, how long will it take for the patient to develop thrombocytopenia? What do you think? Almost immediate. Maximum, guys, within 12 hours, they will develop thrombocytopenia, right? Okay. So either, so you have to make sure this one mentioned in all clinical records, right? It's basically like an allergy, guys. It's as important as an allergy. That is not the mechanism of how this happens. It's an autoimmune condition, but it is as important as an allergy. You all know allergies, we write it with a red pen in the patient's clinical records. Like that, as important as that. You have to write this. Okay. Right. How will the patient clinically present? What's the clinical presentation, guys? No. Very simple. Deep vein thrombosis. Why? Thrombi formations increase, right? Specifically in the deep veins where the blood flow is much slower, right? If the thrombus starts moving around and comes to the lungs, what is it?
Embolism.
Pulmonary embolism. Excellent. Pulmonary embolism, right? So this one is life-threatening, right? So very dangerous. Then we can have again cerebral venous sinuses, guys. In this, you all know the venous sinuses in the brain, right? We'll talk about those in neurology, right? There's this very small or tiny vascular system called the venous sinuses in the brain, right? Here also there can be thrombosis, right? Then again, what about the artery? So these are the vein systems. What about the arterial systems, right? If it goes and lodges in a distal limb or somewhere in the arteries, right? Limb gangrene, depends on how big the thrombi are, but limb gangrene can be there, right? Then in the cardiovascular system, right? Myocardial infarctions, right? Especially the coronary arteries if it goes, right? And then in the cerebral systems, right? What do we have? Strokes, right? Strokes. I'm a little tired, guys. Sorry, today I've been working since 7 in the morning at hospital. Got here by 3 and then 5 o'clock class. Right? Okay. Right. How do we, so these are the arterial ones. arterial, and these are the venous problems. Heparin-induced thrombocytopenia, right? Then, how do we diagnose this, right? This is basically, guys, based on the history plus the clinical. What is the history? Got heparin a week ago, right? Subcutaneous injection. Or in the case of an acute case, I think I remember I had a heparin injection. That doctor said something like a heparin injection. I don't remember the doctor's name. Okay. About a year ago. Okay. That's the thing. And then the next one is, guys, another test we can do is something called the serotonin release test. This is nothing special, guys. We are not going to discuss this. Now, what did we say? Under the granules that are activated platelet releases, what did we say? One of them was serotonin. Do you all remember? Serotonin, we mentioned that, right? So what will happen, guys? You take the patient's serum. I don't want you all to know how to do this. You take the patient's serum, get a donor's platelets, right? And add heparin. What will happen immediately in that sample, in that mixture, right? The serotonin concentration rises. Why? Platelets start getting activated. They get hyperactivated. That's what we said. Platelets start going nuts, right? They go crazy and they start releasing everything. And then they start aggregating also, right? So serotonin is one thing we can easily measure in that sample, right? So serotonin will be raised. Okay. If you all know that much, that's more than enough. Treatment. What is the treatment? Tell me, what is the treatment? Now think of this, the patient, why did you give heparin? He was already in some sort of a problem. That's why to try to solve that, you gave heparin. So now what is your treatment if they develop this thrombocytopenia due to the heparin? What do you think? Okay, option number 1, stop heparin, send the patient home. Option number 2, stop heparin, and you all tell me what to do for option number 2. Definitely not option number 1. Right, good. See option number 2.
Okay.
What can you do? Yeah?
Even alternate anticoagulant?
Alternate non-heparin anticoagulant, right? Okay, this is the first thing. Write down, stop the drug, stop the heparin. Then you continue with an alternative, guys. These two, right? If you all can remember it, right? Not very important, right? There is one that we use, argatroban, right? Right? And the other one, lepirudine, right? Lepirudine. These two, guys, they are again anticoagulants, but their mechanism of action is different. They are direct thrombin inhibitors, right? So they are non-heparin. They are non-heparin anticoagulants. So you stop the heparin, but the patient's underlying cause is not solved. So you can give them argatroban or lepirudine, right? Okay. Right. Clear. Okay. So that's about it for today's class, guys, right? Just write this down. The major thing I want you to know from today's class is what happens to prothrombin time, APTT, right? And TT, which are all normal, right? All normal. This is what we discussed today, right? Bleeding times will be high. Why will bleeding time be high? Right? Because today we are talking about thrombocytopenia. Platelet plug won't form properly, right? Platelet plug won't form properly. Clotting factors can be working, right? But the platelet plug won't form, right? So the bleeding time increases, right? Now, over today, tomorrow, tonight also, I will maybe put about 1 or 2. I will put some questions in the group, in our Telegram group. If anyone is not in the Telegram group, because there only you can try the MCQs, otherwise no point putting it in the WhatsApp group, If anyone's not in the Telegram group, drop me a message. I will send you all the link. I will put some questions. Just try. And don't be afraid to try. No one can see your answers. Even I can't see who answered what. Right? So just give it a go. Right? Just give it a go. Right. Is everyone clear about today's class? All the concepts that we learned. I know today we had a lot of concepts to talk about, right? This ITP, TTP, guys, not the most high yield topic in your written papers, not the most high yield topic in your written papers, but the questions tend to be a bit confusing if you don't know your basics. If you don't know your basics, it's easy to jumble up between the thrombin times, right? APTTs, what is happening, right? Very easy, because now we'll learn several other disorders in the coming days, right? You will see, for example, in disseminated intravascular coagulation, you will see how the APTTs and PTs vary, right? So because of that, if you understand today's basic physio, it will help for the next upcoming classes. If you all have any issues, drop me a message. Give me a thumbs up if you all understood today's class. Okay, right. So my tiring day was not in vain. Okay, I'm happy. Right. If you all have any issues, drop me a message and attempt the questions that I post on the group. I won't post like 10 or 20 in a day, maybe 1 or 2 a day, right? In the coming few days. Okay. Right. Okay, guys. So I will see you all again next week. I think my next topic, yeah, it's multiple myeloma. I will teach you all that. Shan will be having his lecture, I think tomorrow. I'm not sure about the timetable. Tomorrow or day after, I'm not sure. He will put a message. Okay. If you all have any question, drop me a message. Okay. All right, guys. Catch you guys in the next thing.
Right,
Thank you,
thank
sir.
you. Good
Right.
night.
You're welcome. Good night.